Test 1, 2. Testing sound check 1, 2.
Good morning, Tony. Good morning, everyone. Good morning, Tony. How are you? Good, good, good. So I see we only have about, 60%? I think we should start anyway. Good morning, everyone. I hope you all had a very good night and you've had a good week as well. And you are ready for the last day. How many of you are ready for the last day? Oh, only a few. Oh, Ben, I think we need to extend another week. And thank God it's Friday. So we have many things to celebrate. So I think we'll get started. Hopefully our colleagues who are not here will join us very soon. So we're going to have a very exciting Friday morning. We'll start with Ben, who needs no introduction. How many of you know Ben? Or let me say, how many of you don't know Ben? Oh, only one doesn't know Ben. Ben, you'll have to introduce yourself very briefly before your talk. So I think we'll get started. Ben will have 40 minutes. You'll be talking about niche, and I hope you all know about niche. So that will be the first question. Those who don't know niche, maybe we'll extend your flight. And then we'll have, oops, the wrong one. Day 5, we're in day 5. So we'll have 3 case studies. One will be given by Julia, and then Andelight and Elizabeth. And then we'll have discussions after. So Ben will have 40 minutes, and each of the 3 case studies will have 20 minutes. If you can at least spare 2 or 3 minutes after your presentation for questions, that will be great. So I think we'll get started. Ben, floor is yours.
Thank you so much, Jason. And keep a mic in hand, Jason, because I will bring you in my presentation at some stage. Good morning. Day 5, how are you feeling? Good. Inspired. And would you guys want us to extend it for another 2 days? All right, we can certainly do that. You just need to pay. No, if you're paying, no, eh? All right. So my name is Benjamin Kagina. You call me Ben. I am the co-director of Vaccines for Africa Initiative. And I direct a project we call NICHE, All Night Support Hub. And I'm going to tell you a lot about it. But before I get started, we have hosted you for the week. Right? Remember when we started, I called the VACFA team, they introduced themselves to you, and we sort of agreed that you need to engage them. So how many of you know what VACFA does? Just even if it's one activity that you think, or one thing that you think we do? AAVC? That is correct, because if any failed that, we're just going to cancel the certificate. Okay. All right, what other thing do you think we do? We engage the NITAGs. We develop also NITAGs, all right? When we started, it was very good to hear all of you have a hand and contribution to the work of in the field of immunization and vaccination, all right? But I asked you that day, how many of you know about NITAGs? And there were very few hands. But then we had an introduction of somebody who said he's a NITAG member. I think it was Joyce, and explained what NITAGs do. And after that, when I asked you, would you like to contribute to the work of NITAGs? by show of hand, almost everybody said that they would want to, correct? So we do support NITAGs through training and also hands-on support. What other work do you think we do? Okay, we've said training in vaccinology, research, right? We also do training of postgraduate students, right? What else do you think we do? All right, so it's the whole space of evidence-informed decision-making. Correct, right? We also train students, okay? I know you say training in vaccinology, ADM. We also do training of postgraduate students. But I think what is unique about what we do, every single piece of it, even for the student, it connects to evidence-informed decision-making. So we do so many activities. We do advocacy and communication work, but everything connects to generating evidence or using evidence to advance immunization practices. All right. Do you think we can do that? Oh, importantly, very important, we have Vaccines for Africa initiative. So our focus is the whole of Africa. Do you think we can do that work from Cape Town and manage to do much? No. Okay. So what do we do? What do you think we love doing? Collaboration. Okay. That is exceptionally important for us. Partnership and collaboration. And what you realize as I give this talk is some of the skills that we need is so unique. Sometimes we don't get it. We've gone for about 3 years without filling some posts. So that is why you are so important. And at the end of this talk, when you ask me a question, I'm going to also ask you a question, which is, what can you do to contribute to support the work of NITAGs? All right. Okay, I'm going to get started. So I've got 3 objectives for this talk. The first objective is to get us on the same page on what we mean by evidence-based recommendation or evidence-informed decision-making. There's a lot that has come up during this week about evidence, data. So can I just get some few, 2 or 3 people volunteer to say what they understand by evidence-based? Do you think our elections are evidence-based? Eh? Yes. The result are not. Okay. But let's put it in the context of public health. All right. There's a hand there, Salim.
Research findings. To use research findings to orient the decisions that need to be taken at the implementation level or political level based on what has the body of research found, and in the same time connect with implementation and decision-making people to orient the research that need to be conducted. So vice versa, it works both ways.
Excellent, excellent. All right, so it is the use of research evidence to inform decision-making. Okay? Is all research good? Why not? Sorry? The quality of evidence.
And hierarchy also.
All right. How many of you have come across a bad quality research? Are you the one who has been rejecting my papers? Oh, Elizabeth, you want to contribute?
Yes, I have. In the infamous Wickfield, even though it's been retracted, but it's still accessible. And when I read it, I knew it was bad research.
Okay, thank you. That's true. So there was somebody who said that, I think it was Latif, that in Malawi, I think they took religious leaders and took them for training. And after that, they sorted the problem of COVID-19 vaccination. Is that correct? Is that good evidence? You're the one who told us this, Latif.
Anecdotal evidence. It's the worst form of evidence.
But it seems it worked in your setting.
No, it wasn't proven to. You can't generalize it. Yeah.
Oh, okay, good.
Yeah, it's sampling variation. Yeah.
Yeah. All right. Thanks. I think the types of evidence varies, and sometimes just observational evidence. I'll give you an example. There was a district in South Africa where they found that if they go for immunization on, I think it was Tuesday or Wednesday, they were getting very few caregivers showing up to bring their kids for vaccination. But when they changed that day to, I think it was Friday, the numbers doubled. And there was a reason behind it. So no controlled study, but it was evidence, observational. And when they changed that, they started seeing increase in coverage. So there are different types of evidence. And I want to make a strong case for us on the continent. A lot of evidence is in our heads, right? And it remains there. So how do we, if you generate this evidence in Malawi, and I'm in South Africa or in Kenya or Mozambique, how do I know that this works and this doesn't work if it's not documented? It's difficult, isn't it? So there has been a lot of recurrent message that we have many evidence gaps on the continent. And to some extent is correct. But to some other extent, I think the evidence is there, it's not accessible. And I think it is our responsibility, all of us, to make sure that that evidence is made accessible. I know publication fees sometimes can be quite expensive, but now with social media and many other channels of communication, I think we can share more of what works, because doing research on something that doesn't work is not good use of resources. Okay. So we've heard about pyramid of evidence. So at the top are systematic reviews, followed by, so these are type of studies where you collect evidence from different sources, but there is a process of doing that. You ask the right question, follow specific process, and conduct a systematic review. You can also conduct a very poor quality systematic review. So you need to make sure that whatever you include in your systematic review is good. All right, then you've got critically appraised topics, all the way to the expert opinion, what we are discussing about the Malawi case of observational type of evidence. You can see, importantly, randomized clinical trials are in the middle. And they are very important because of the design, how we control for bias, how we control for other things. So understanding that not all evidence is the same is very important. Understanding this is the evidence we use to make decisions, it's very important. And understanding how to assess the quality of evidence is important. There are tools to do that, all right? But the purpose of this talk is just to tell you there are different types of evidence. Not all evidence is good, okay? So you need to always question the evidence, how it was generated, the source, and so forth. So when we talk about evidence-informed decision-making, what does it mean to us, okay? It means making sure that the evidence take into account the local context, to take into account the politics around it. Research, of course, we've talked about it. And of the issue of resources, health system. And in that intersection is public health expertise, vaccinology expertise. So when we do this course, building vaccinology expertise for Africa, we want you to be in that intersection, that you're not only relying on one piece of evidence, you look at different multiple types of evidence. Again, look at the quality before you make decision. So there's very clear guidelines at global level on how evidence-based recommendation for vaccine should be made. This is done through SAGE, Strategic Advisory Group of Experts on Immunization. And if you go to this link, it gives you a very clear stepwise process, how evidence-based decision-making process is done. Okay, they've set the standards, wonderful standards that have been in existence for long. And the idea has been to duplicate these standards at regional and national level. So let's look at the levels of evidence-informed decision-making for immunization policies. At the top, we have the SAGE, which is global. Then in the middle, we've got RITAG, which is the Regional Immunization Technical Advisory Group. And then at the bottom, we've got the at national level, which is where NITAG's at, okay? And there has been a challenge in the way the communication between the SAGE, RITAG, and NITAG happens, but there has been quite a lot of effort through the global NITAG network, and also to make sure that there is representation of NITAG members in RITAG and also NITAG members in SAGE. And also SAGE members attend the RITAG meeting, and NITAGs can have direct channel to communicate to SAGE. Right. So for this talk, obviously, I'm going to concentrate on the NITAG at national level, because that is why I want you guys to think about what can you do. Right. So hope we're on the same page on what it means to do evidence-based recommendation, or what it means to say evidence-based recommendation. So the second objective is for me to provide you with insight on NITAGs and the process the NITAG used to make evidence-based recommendation or evidence-informed decision-making. And in this process, I'm going to make a very strong case that we need NITAGs. Okay. So definition and function, national experts that provides technical and scientific guidance to the government, specifically Ministry of Health, on matters related to immunization. It is independent, right? It is an independent, and its work is scientific. It's conduct best possible review of scientific evidence before making a recommendation. It brings credibility to our national immunization program, and this allows minimization of pressure from interest groups. Importantly, a functional NITAG needs to be able to provide timely evidence-based. It is important to know that simply because a country has a NITAG, it doesn't mean it is functional. It's very similar to vaccine introduction. You introducing a vaccine does not mean you reach the optimal coverage. All right. And I think there is a lot of work that is needed to make sure that our NITAGs that we established stays functional and gets better. There are many factors that influence their functionality, and we're going to come to that. So quickly, this is just to tell you that there are best practices on how NITAGs should be composed. Importantly, it needs to have ministerial mandate to do. Ministry of Health has to give NITAGs the mandate to do the job. There are different types of membership. And in the middle, where you see core members, That is where the issue of independence comes from. Okay. So what kind of expertise do you think the core members need to have to help NITAGs make evidence-based recommendation? You can shout wherever you are. What kind of expertise? Microbiologist? All right. Vaccinologist? Behavioral scientist? Immunologist? Health economics? Health system expert? Do you see that diversity of expertise that is needed? So you can imagine if you bring all that diversity of expertise into one room and they have to make decisions on vaccines and immunization. It's a very rich group, but you can start understanding challenges because they look at things from a different lens. Right. And the challenge has been, how do we make all these diverse expertise be on the same level so that when decisions are being made, they can optimally utilize that diverse expertise? Okay. So this is just some examples of the expertise represented in NITAGs. Okay, let's see how an ideal NITAG should follow the process of evidence-informed decision-making. So typically the Ministry of Health submits a policy question. Usually this is very broad question. So they could ask, should we introduce HPV vaccine as an example? Or they could tell you to advise us on whether we should change how the schedule we are using for HPV. Let's say you're using 2 or 3 doses. They want you to think about whether 1 dose could be used because the Minister of Health and EPI team have read other countries are using it, or there is WHO position paper on that. So then NITAG forms a working group, and the working group refines the policy question because when the ministry gives NITAG a policy question, it is very broad. It is important to say that NITAGs can also raise their own policy question. You do not have to wait. They do not have to wait for the MOH. All right, then that policy questions is refined using a framework we call PICO, population, intervention, comparison, and outcome. So this is an example of population being girls, intervention being single dose HPV vaccine compared with 2 or 3 dose HPV vaccine. And then the outcomes, it's NITAGs to decide. And this process is very consultative, all right? That's why all those expertise are needed. So when working group is formed, it can co-opt members with expertise on the topic being discussed, all right? Then where things become tricky and even very important is what we call evidence to recommendation framework, because this has been established as the right process through which evidence-based decision-making should be approached, all right? So there are different criteria that NITAGs consider, and I think Karine mentioned about this. But after all that process, NITAGs prepare a recommendation and submit to the Ministry of Health. Then it's up to the Ministry of Health to consult internally, and if need be, with other stakeholders, especially the Ministry of Finance, and decide to implement or not implement the recommendation. 2 important things to mention. It is becoming now very clear, countries that have functional NITAGs, the Ministry of Health is more likely to implement the recommendation made by NITAG compared to countries that don't have functional NITAG, right? Another important piece, this is very important, especially for Gavi-funded country. You heard Michelle say that some of the funding from Gavi, the condition is that you have a recommendation from NITAG. So some of the delays we had with PCV introduction and rotavirus vaccine introduction in some countries was because there was no NITAG to make a recommendation, so Gavi could not fund it. All right. So what are the types of evidence that NITAGs consider in their decision making? It's several types of evidence, all right? And that is why all these expertise is needed. So the disease burden, the feasibility, equity, safety, efficacy, acceptability, all these are types of evidence and possibly much more. We talked about the need for MR and microbial resistant to be incorporated in the kind of evidence NITAGs use for decision making. Right, thankfully, we do have some NITAGs in the room. Okay, and I'm just going to invite two NITAGs who are here who want to share some of the challenges that they've experienced when making evidence-based recommendation in their countries. Okay, we start. Do you have a mic? For the interest of time, we're going to just hear from one NITAG, and then we're going to hear from the chair, Jason, who has actually worked a lot with NITAGs on vaccine introduction.
Thanks very much. This is Irisa from Uganda. So, yeah, I came up with five challenges, and of course, I had to liaise with the secretariats back home. And of course, central to decision making is evidence-based. However, we have challenges in getting up-to-date local disaggregated data. For example, especially diseases that are not under active surveillance, getting information about them is difficult. Economic data like cost effectiveness, social data like acceptability among communities, that one is a major weakness. And of course, even information on logistic requirements such as cold chain capacity. You find that the expanded program on immunization in the country is usually very busy, and they're not always available to support the NITAG whenever we need some of these data requirements. Then secondly, access to publications that are not open source. You find that, yes, we have to look for peer-reviewed information from reports, but you find that some of this is not available. But it's nice to say that the niche library usually supports, and even WHO. Then working on a NITAG is voluntary and it's not paid. We are not paid. So you find that, and people are very busy. So you find that scheduling meetings, members are always busy. But of course, now we usually conduct hybrid meetings so that those ones who cannot make it to the physical meeting are also represented. Then our secretariat team is small. Okay, we have a small team, but then the workload is heavy. For example, this year there is a time we had to decide. I think there are about eight different vaccine candidates, and we had to go through a rigorous process, and of course the secretariat is small, but then they get technical support from the WHO country and regional teams. Then this is my own reflection. At times we come up with evidence-based recommendations, but then you realize that actually there is a desired position by the ministry. That one happens, okay? But of course the thing is, we give you what we have. It's up to you whether to implement it or not. Thanks very much.
Excellent, thank you very much. Any other experience from other countries that you want to add to those challenges? Just add what he hasn't mentioned. First, say whether you agree with the challenges he's faced.
Good morning, team. Yes, he's absolutely right.
Great.
That is what NITAG is facing most of the times. To add on what he was saying, in the case of my country, when it comes to the secretariat, we are.
Which country?
Botswana. Sorry, Botswana. Yes. So we are we have realized that Secretariat has a lot of work to do, more especially when it comes to leading the evidence generation. And it was taking a lot of time. Like he said, the NITEX representatives are volunteers. So now what we have decided to do in the last meeting is to partner with the University of Botswana to lead the secretarial role, whereby they'll study the evidence generation, and thereby when the NITEC gather, there's something on the table. So we hope going forward that will really help. But the other challenge that we are also facing is the finance. Doing all this that requires finance. So of late we are struggling in that area. Thank you.
Absolutely agree with you. And just for the interest of your time, if we have during Q&A, we're going to come to you. The worrying thing is that these challenges have been there not for 2 years, not for 10 years. They've been there all along, right? And as we come with these bold ideas of ring-fenced, was it the red team? I hope in your ring-fence budget, you have budget for NITAG. Okay. Jason, do you want to add anything that you've experienced when you're working with NITAGs, when you are wearing a WHO hat?
Yeah, thank you very much. I think what a colleague from Uganda mentioned, I think is real and is, I think it's common in most of the countries, particularly with the introduction of new vaccines. We also have the influence from the vaccine manufacturers, who sometimes go to the country and they meet with the minister and they influence the minister. And then the minister then sort of makes a decision that perhaps we should produce vaccine X where there are two options. And then because the minister knows that for countries that are Gavi eligible, Gavi will not approve if there is no NITAG recommendation. So then the minister sends that request to the NITAG sort of to endorse it, but the minister already knows which vaccine. So it sort of creates a bit of a dilemma on what to do. So that's one. The second one is on the data. I think the colleague from Botswana mentioned, where you need data, credible data to make a certain decision. And sometimes you need local data and that data is not available. So what do? Do you use data that is, data that is not good quality data to make a decision, or do you use data from a neighboring country or regional data or global data to make certain decisions? So these are some of the issues, Ben.
So Jason, what do we refer to that evidence from the minister coming to NITAG? Should we call it minister-based evidence? All right, she wants to add something.
Just to add few challenges that I observed as being the technical partner from WHO sitting in the NITAG as a observatory member. So I agree with everything that colleagues already said. And I would add to that that vaccinology expertise is so hard to build that it is theoretically in our settings impossible to do the rotation that is recommended, which brings fresh perspective to the NITAG every now and then. So people can be in NITAG for 20 years plus sometimes. And if certain relationships are already built with ex officio members, the government members, and like they try to influence the decision making within the NITAG, not based on evidence, but based on operational perspective. And as the minister recommendation, it's really hard because the core voting members are sensitive to the government request and recommendations. So sometimes it is unclear what is the role of non-voting members. They tend to influence or take most of the communication and discussion space, that it is hard to make really informed decision-making recommendations. and also sometimes it's like for new vaccines and underutilized vaccines, specific expertise is required. For example, specific social and behavior understanding, which usually doesn't exist within the NITAG, and sometimes they are not properly equipped to take the right decision or to give the right recommendation, and to go and get the right behaviorologist and the right expertise and bring into the NITAG on a voluntary basis is quite difficult.
Thank you so much for sharing that. I fully agree. And those are the challenges that actually triggered us to think, what can we do? All right. This course is now 20 years old. We started engaging with NITAGs 10 minutes. All right. We started engaging with NITAGs around 2013 when they started coming for this course. And these things kept on coming. Over coffee, you know, we have this problem. And the bad news is that the problem is going to get more complicated as we move to life course immunization. Correct? You heard about it. So currently, most of the policies that NITAGs are working on is based on childhood vaccines. And now we heard about recommendation on vaccination in pregnancy. We have HPV for adolescents. It's going to get more complicated, and Ministry of Health will definitely need the technical guidance of NITAGs. And now if NITAGs don't have the resources, they are not supported, it's just going to become impossible. And we need NITAGs. We need to support them. All right. It doesn't end there, right? If you look at the horizon, there are more vaccines that are in the pipeline. And these are vaccines that are likely to have huge public health benefit on our communities. Now it starts becoming even a question of, and there are more vaccines in development, it starts becoming a question of which vaccine do you prioritize to introduce? And as more vaccine options becomes available in the market, we need to revisit the types of vaccines we are using. So a very good example is the 2-dose HPV, which has now been revised to 1 dose, and it has huge public health benefits. So if you saw the sort of some of the goals that Gavi had set, increase in the number of HPV vaccinated girls, that largely has to do with the change from 2-dose to 1 dose because it's easy to administer 1 dose. So the challenges keep on getting bigger, and I don't think we're investing in NITAGs equivalent to the way the challenges are increasing. All right, thankfully, the continent has realized the importance of NITAGs through advocacy, through engagement. We can see there is more and more countries that have set up NITAGs. And what is important is that most of these NITAGs are now functional. All right, you can see in from this map in 2011, we had only about 6% of the countries in Africa, and this is in the Afro region. But as of 2023, almost 90% of the Afro region had NITAGs set up, and most of these are functional. So the last objective is to show you, give you some insight onto the niche project in the context of addressing the needs and challenges of NITAGs. And of course, we cannot address all of them. So our focus was mainly on the scientific, not administrative. All right. And this is where I would like to make a case to each of you. Those who already are playing a role, that is excellent. But those who are not, just ask, can you do something to support the work of NITAGs in your country? All right. So what we did at VACFA through this kind of engagement, and we do a lot of reviews, we realize, look, on the continent, NITAGs are battling. There's challenge with financial resources. There's challenge with experience sharing, capacity development in vaccinology and evidence-informed decision-making. Access to NITAG tools and research evidence. And we said, look, there's something we can do. Okay. So through these kind of forums, we engaged with NITAGs. That was between 2019 and 2020. We did literature review to look at the needs and challenges of NITAGs more broadly. And we did an online survey to ask NITAGs, what are your challenges and what is your perception of us setting up a NITAG support hub niche in Cape Town, hosted by VACFA? And the findings were exceptionally overwhelming. NITAGs in Africa said, we want to have niche. And out of 60 responses that we received, 59, which is almost 100%, said they would be happy to support niche establishment. And what is important, they also defined, they told us what kind of support we should prioritize. Okay, so that is how we established NITAGs. Thankfully, we worked very collaboratively with WHO in this exercise, and Wellcome Trust was on our side. And these findings we presented to them, and they said, we're going to fund you to establish a NITAG support hub. And 4 years now we've been running. One of the biggest challenge has been to find the right staff to do it, to do the support of the NITAG. And it's because of the specific niche of NITAG's work that we do not have capacity on the continent. That's why this course is very important. And it's not just this course. When you go back, there are many other courses that can equip you better to make sure that you are able to contribute to the work of NITAG. So we set up a website, and I would highly encourage you to go and look at our website, because that is where we post what we do, what we are currently up to. Some of the research evidence is accessible. We do have a librarian. So for the articles that NITAGs are not able to access because of paywall, we can be able to find those for them. So these are the services that NITAG said we should prioritize. So it's supporting health system in the context of, and this is in the context of evidence-based. Then design thinking, which is literally working with the communities, working with the user to understand the needs so that the solutions that are developed are very context specific. And evidence-informed decision-making, both training and support. The application of health economics in decision-making was something that NITAG said, and most NITAG struggled to have health economics in their core membership. And importantly, mathematical modeling, because model-based evidence is becoming a very important tool to support the work of NITAGs, especially where there are data gaps and decisions need to be made. It's better than not using anything, okay? And all this, the intersection is vaccinology training. So we invite NITAGs in a 5-day course. It's called Annual Vaccinology Course for NITAGs, which I'm gonna speak to this, the middle one. We started in 2022. So invite NITAGs as a group, about 6 to 7 members, and we train them. So their training is very different to this one, but the experience we had from this one, we applied it to the vaccinology course for NITAG. So we do also have short courses that we give to short training in vaccinology that we do with partners through the process we call evidence to recommendation training. And of course, you all know about AAVC. So access to evidence has been a very key priority need for NITAG. So we've got a librarian who has developed niche library guides or LibGuides. And these LibGuides, the topic for LibGuides is actually informed by NITAGs. So all the COVID, malaria, HPV, etc., they all been informed by NITAGs needs. And these LibGuides collect all the evidence locally and also from the articles that are from WHO position paper. And this makes it easy for NITAGs when they want to use evidence, they can go to LibGuides. And if there's anything missing, they can tell us. So Jason, I'm finishing. So this was a meeting that was in the SAGE meeting, and you can see on the continent, we have niche as the main partner supporting the work of NITAGs. And we cannot do all this from Cape Town. We need to collaborate with you. We need French-speaking vaccinologists. We need Portuguese-speaking vaccinologists, because as a continent, we've got those three main languages. So Jason is working for us, English-speaking. We've got somebody from Cameroon, a Posi working for us, French, but we've struggled to find a Portuguese-speaking to help us during night times. I think that is it, Jason. I started a bit late.
Thank you very much, Ben. We gave you a few minutes because you're the boss. But we have 3 minutes for quick questions, clarifications. I know we started the discussion, but if you have any question, please.
Can I ask them to also tell us how they feel they can support the work of NITAGs in your own way? If you don't have a question, I can ask you a question.
Right, yes. Seppi?
Thanks, Jason. We have a question from Abdul online. He says, Prof. Ben kept emphasizing functional NITAGs. So he's curious to know what separates a functional NITAG from one that exists only on paper. He also wants to know what are the current African numbers, or how many African countries have NITAGs, and how many actually meet the WHO functional criteria.
He seems to know the answer because he's saying the WHO. Is his name Abdul? Yeah. So Abdul, there is the WHO NITAG functionality criteria. I think it's 5 or 6. You know, you've got that legislative mandate from the Ministry of Health. You have terms of reference. You do have the conflict of interest declaration that should be there. You should also have the expertise that are represented in your NITAG. And importantly, you should be able to meet at least twice a year, and at least you make a recommendation in a year. So there are WHO criteria for assessing functional NITAGs, but what has come up is that alone is not enough. So there is a new tool which is called NITAG Maturity Assessment Tool that takes into account the process of decision making, because that also influences how functional the NITAG is.
Okay.
Abdul has a last question.
Oh, a quick one.
His last question is, so in countries that do not have a NITAG, he wants to know who then gets to make decisions on which vaccines to roll out. He just wants to apologize as well. He's like, he might have missed a slide or two.
No. Abdul, that's absolutely fine. Jason, do you want to help that from WHO side? Countries that don't have NITAGs.
I think the countries are advised to sort of bring a team of experts, even though the NITAG has not been sort of legally established. You could use the expertise in the country, for example, from the universities to help, you know, the Ministry of Health make decisions on vaccines and vaccination.
And Abdul, just to mention that in terms of the number of countries with NITAGs now, I think the last time I talked to Sidi in Afro region, out of 48 countries, was telling me we've got just about 4 or 5 countries that don't have NITAG.
Right.
Okay.
So I think I think we'll move on because we are running out of time. Thank you very much, Ben. I think it deserves a better clap. So you know about the NITAGs and how they function. So we can now move on to the next presentation. So we have Julia from the University of Amsterdam. We'll start off with the case studies, some of the work that Niche and VACFA is doing. Julia will talk to us about the critical systems theoretics approach, exploring new TB vaccines implementation in high burden countries. Thank you. Over to you, Julia.
Good morning, everyone. My name is Julia Rokomaki. I'm a medical doctor, and I just finished my master's in global health in the Vrije University in the Netherlands. Earlier this year, I did a study, part of my thesis with VACFA, supervised by Prof. Ben and Rudzani. And what I'm going to be talking to you about today is a critical systems heuristics approach, exploring the new TB vaccine, specifically M72 implementation in a high burden African context. I'm going to ask you guys, how many have you heard about critical systems heuristics? A bit, a little bit maybe, yeah. Okay, perfect. Then I can explain. So critical systems heuristic is a framework that I used in this study. I'm going to go more deeper to it later. In this presentation, it says that this is for high burden African context. The study was done majorly focusing on South Africa, but I think there are a lot of points that you can try to reflect on your own country and on vaccine implementation, even though there are differences, but hopefully there's something useful out of this. So there's just the agenda. I'm going to explain the background, methodology, results, discussions, and summary. Start with the background. Most of you are familiar with TB. TB is the leading cause of death from a single pathogen worldwide. And an estimated 10 million people fell ill with TB worldwide. And from these 10 million, a quarter of new TB cases were in the African region. And 33% of TB deaths occurred in the African region in 2022. So we all know how big the TB burden is in this specific region. So South Africa has one of the highest burdens of TB globally. In 2021, South Africa alone had over 56,000 people dying to the TB, which means that it's about 153 people a day. That's 153 people too many. And the TB has primordial distribution, so it means that it peaks during the early childhood and then later among adolescents and adults. And HIV is one of the most important risk factors. So the current TB vaccination, as you might know, is called the BCG TB vaccine. It was invented in 1921, which was over 100 years ago. And after that, there have been some other vaccine candidates, but they haven't been successful in the clinical trials or to be implemented in the EPIs. And the BCG is given at birth to infants and is protecting from severe TB, so from miliary TB, TB meningitis. But it has a limited and variable protection against the pulmonary TB in adults. So about the new TB vaccine. So the M72 that already, I think Thomas Kriba mentioned earlier this week, is a fusion protein a vaccine with the adjuvant from GSK. Its primary indication is the prevention of TB disease. So as we know, the TB, when it's contracted, it usually becomes latent in your body, and later it's activated if you become immunocompromised or due to comorbidities, etc. And then it becomes the infective form of TB. So this vaccine is specifically preventing the latent TB to become an active TB disease, which is the infectious form. So why M72 TB vaccine? So already that is mentioned earlier this week, maybe you remember, but it showed a 50% efficacy in phase 2 clinical trials preventing pulmonary TB. And there is currently a phase 3 study underway, and it's promising with individuals with latent TB, like I just mentioned. And hopefully, if it's enrolled, it could reduce TB incidence by targeting adult pulmonary TB, which is the main source of the transmission. So I'm just going to briefly mention the vaccine delivery landscape in South Africa, so it helps you to create a bigger picture what we are investigating in the study. So the EPI focuses mainly on childhood vaccination, and adolescents and adults, especially healthy ones, are not usually included in the routine vaccination efforts. So that's where the kind of issue comes from with the implementation of the TB vaccine in the future, since there is no immunization program for these groups that are needed to be, who are included in the implementation of the vaccine, which is adolescents and adults. And these people might be people who have never had a contact with the healthcare services, are not familiar with it, and could be very hard to reach. And the vaccine delivery is managed through a top-down approach from national to local levels. And that creates challenges with the fragmented governments, health system constraints, and especially with the infrastructure. So the research question in this study was, how can the M72 vaccine for adolescents and adults be effectively implemented into South Africa's health system through collaborative efforts between stakeholders while addressing systemic barriers, promoting equity, and ensuring sustainability in a high TB burden settings. About the methodology, though the study was a qualitative study that was held between interviews with key stakeholders that are involved in a TB/vaccination research, immunization policy, and delivery. In total, I concluded 13 semi-structured interviews online, and the participants in this study were quite a big variety of stakeholders. So there was technical advisors, EPI managers, different TB-related researchers representing philanthropic organizations, Ministry of Health, NITAGs, academia, etc. So now about the critical system heuristics. So critical system heuristic framework alongside another tool, multiple perspective tool, is to explore systemic conditions that are shaping the implementation of the M72 vaccine. And the critical system heuristic is a systems thinking approach designed to critically reflect on decision-making processes, particularly in complex societal systems. So when we think about implementation of a new TB vaccine, that is a quite complex societal system that we're trying to implement to it. This has a lot of different stakeholders that have a different power in decision-making as well. So here I wrote down 3 words that kind of open what the critical systems heuristic means. So critical means reflectively inquire into the validity of current thinking with the quest to uncover improved ways of pursuing and viewing the situation. Systems seeking a holistic view and solution, one connected with past reality, but also seeking future relevance. The process itself is one of the suing in views as opposed to seeking one ultimate correct view and solution. Heuristic is a process where all participants in the situation collectively learn their way towards a shared understanding and alignment around the action. So the critical systems heuristics has not previously been used in vaccine implementation studies. So it's quite new in the public health sector to evaluate the decision-making and the ethics of the decision-making and the power dynamics. And it was originally developed by Werner Ulrich, and it was later adapted by Strümpfer in 2022. Yes. So here you can see, I wanted to include the sub-questions here because I think they reflect very well on the 6 boundary categories, which are transformation, beneficiaries, purpose, measures of performance, assumptions, and constraints. And these sub-questions, yeah, they are answered in this research directly reflecting to the 6 boundary categories. So these all 6 boundary categories are interconnected. And when we are, when I'm conducting the stakeholder interviews and trying to figure out what is needed for a successful implementation, all these questions needs to be answered to present these multiple perspectives. And that's what I'm going to show you on the next slide. So here we see multiple perspectives. So the multiple perspective tool is integral to this critical systems heuristic that I told you about. And it acknowledged that there is no single actor holds a complete view of the system. So you can see, we can imagine there is the knowledge that's the whole brain is a knowledge. All the knowledge we have about implementing a new TB vaccine into a specific health system. We have all these different perspectives. Let's say one is an EPI manager, one is a TB researcher, one is a NITAG member, etc. Or they could be a combination of many different stakeholders. And we need as many perspectives as possible to understand the full knowledge that we have about how to successfully implement. So the multiple perspective draws on diverse viewpoints that uncover the assumptions and power dynamics. So then it can also provide a more nuanced approach to actually critically examine the boundaries and relationships within the complex system. And here is also, you can see the picture represents a research approach based on the Strumper's multiple perspectives. So you can see here the participants. So here I've put 5 participants, and I just want you to emphasize how does the critical system heuristic and the multiple perspective tool work together. So each participant create perspectives. And some of these participants, 1, 2, 3, multiple participants can create a safe perspective. Let's say one perspective is that for successful vaccine delivery, there needs to be multiple different platforms to deliver the vaccines. So we look into these perspectives, and we form all these perspectives, as you saw in the previous picture, that are forming the full knowledge of the vaccine implementation. From that can be formed causal loop diagrams that we can look into variables and actions to actually see what is needed for this implementation. Yes, and then to the results. So here you can see the multiple perspectives that are formed from the interviews with the stakeholders. So these are the multiple perspectives that we found that are needed to make a successful implementation of the vaccine. The first one, you see the high vaccine coverage for target population. So there I'm explaining that the transformation means that transformations capture how participants envision the system evolving from its current state toward the desired outcome. So here we would have an absence of TB vaccine program according to the participants. And out of the transformation, we would get a protection of high-risk groups with M72. The beneficiaries, so the people who are benefiting from this transformation, are people living with HIV, underserved communities, and high burden areas. And the purpose of this transformation is to ensure fair allocation and maximum impact for a limited vaccine supply. The measure of performance is a set of measures that would be critical to assess, have we been successful in the rollout? This would, in this first example, represent equity indicators, population coverage on high-risk areas. The assumption in this transformation is that the high-burden communities are a priority target. And what would be the constraints and the barriers to reach this transformation would be limited experience outside infant vaccines and inadequate data systems. So this was the first perspective that was formed to the participants. The second one is hybrid delivery models. So for the transformation, we would need multiple different delivery models to get a broader population coverage. The beneficiaries in this case would be people living with a high risk of TB. The purpose of this would be improve accessibility and equity on M72 delivery. The measure of performance would be coverage rate across diverse delivery channels and reach underserved population. Assumption would be that taking services to communities increases vaccine uptake. Yes, then I'll show you the next ones. Though the third perspective that was formed from the stakeholders was system capacity for scale up. So the transformation that we would need would be, we would put inside to the transformation would be adequate funding and workforce, and we would get a timely rollout without compromising other services. The purpose would be ensure that the rollout does not overburden the existing health services, for example, primary healthcare or delivering other vaccines. This we could measure by health system readiness and minimize disruption of routine care. And the assumptions would be that current health system is under a pressure and cannot do a major vaccine rollout without extra support. The fourth one that I'm going to mention is adequate vaccine supply, which would mean that we need a intellectual property reform, pooled procurement, and what we would out would be a stable supply, affordability, and increased equity when it comes to M72 vaccines. The beneficiaries would be TB endemic countries and underserved populations. The purpose would be to ensure affordable access to M72 for high TB burden countries. How we could measure it would be through vaccine price transparency, licensing agreements, proposition of M72 supply manufactured domestically, that was also talked multiple times earlier this week, and that the global stakeholders will act in solidarity, but also that the manufacturers will agree to share the IP. Here you can see the causal loop diagram. So this is a modeling connectedness of variables and actions associated with the M72 implementation. So you can see with the plus, it shows how they, these specific variables that were identified from the interviews are shaping each other. So I'll give you an example. the screen is a bit light, but for example, to get a successful M72 vaccine implementation, we would need increased community engagement. That would affect to increase community trust, which would affect to increased vaccine acceptance, which would increase vaccine uptake, which would finally help to have a successful M72 vaccine implementation. And this is important that we identify these different variables, because otherwise it would be just easy to say, oh, to have a successful vaccine implementation, we need increased vaccine uptake. But here we can recognize the variables and also use it more better to measure if we're actually reaching these variables and how they are working to be successful. Because it was a qualitative study, I want to mention a few nice excerpts that came out in the interviews. The first one is about decision-making. Manufacturers are the ones making the key decisions. The profits and losses are the main determining factors of vaccine and how they progress along the pipeline, by a TB vaccine researcher. I had two ones on equity. So achieving equity is complex. Marginalized groups have historically been the last to benefit from new vaccines, despite often participating in clinical trials, by a TB vaccine researcher. And this excerpt reflects on how actually the communities that are participating on these clinical trials might not ever get access to the medication permanently that they have been part of developing. You would definitely not want a situation where low TB burden countries suddenly decide they want to vaccinate all their people at the expenses of high TB burden countries by a TB researcher / TB physician. And I think this quite well reflects on the situation, for example, with COVID, where in the global north, there were already countries receiving third vaccines when people in the African region were still waiting for their first one. And the last excerpt about logistical barriers. Local manufacturing would be a big advantage. If you can manufacture M72 vaccine locally, it's closer to where you want to distribute it as well by a technical officer. And this is something that has been talked this week earlier about the regional manufacturing of vaccines. And some of the participants also mentioned that they have noticed that the people participating in a rollout and receiving the vaccine do trust the vaccine more when it's produced locally rather than outside the region. So about the discussion for the strategies for sustainable implementation. The first one is important. There will be, according to the interviews, that there will be early planning. So it's too late when we already have the vaccine done through the clinical trials to actually implement it. Where are we going to put it? Who will distribute it? So the local manufacturing would strengthen the preparedness and distribution. Early community engagement builds trust and counters misinformation. Then about the vaccine delivery. So the target group for the rollout would be people with highest risk of TB. And it would be important to leverage this delivery into existing platforms. Then about equity. So the target high-risk groups would be use local data, so not just broad national strategies. When you roll out the vaccine, you need to actually know who you're going to roll it and what are going to be your target audience and what are you going to actually do to make it properly roll out. And also to promote community involvement in planning to avoid top-down approaches. Then on the summary, M72 vaccine is seen as a crucial tool for reducing TB burden, especially in high-risk groups. Decision-making is shaped by power dynamics, with strong influence from manufacturers, global actors, and limited community input. And the third one is the hybrid delivery platform that came across many times during the stakeholder interviews, which recommends actually combining school-based programs, health facilities, mobile outreach, and integrated services to actually reach the diverse groups and maximize the equitable access. So you need to distribute the vaccine where actually the people are, maybe in a football stadium, in a game, maybe in a bar, maybe even that, to actually reach the people that are not accessing the healthcare services before. And about the critical system heuristics, it quite well describes how better outcomes emerge when decisions involve actually diverse perspectives, power imbalances, and include those who are most affected. And it's a reminder that effective vaccine policy is ultimately a matter of both public health and social justice. And I know I'm late, but I think I want to read down these questions just to plant a seed in you in the audience. You can think about, maybe talk later with your neighbor or something about the future vaccine implementation in your country. So what would your health system need to successfully implement a new TB vaccine? The second one would be, when making decisions about new new vaccine implementation, whose knowledge should matter the most? When program like this gets rolled out, some people might benefit more than others. Who do you think might be left out and how this could be addressed? Yes, thank you.
Thank you very much, Julia. I hope you enjoyed that presentation. So if you did, please just write down your questions, your comments, because we'll move to the next case study. And then towards the end, we can have a general discussion on all the 3 case studies, including the ones online. Okay, so we'll move on to the next case study. So we invite Angela Gina from the University of Cape Town. You talked about the case study. This will be examining the vaccine decision-making ecosystem in Southern Africa. So Adelaide, you have 20 minutes.
Okay. Good morning, everyone. My name is Dr. Masu, and I work with VACFA and UCT. And we did a study called the Vaccine Decision-Making Ecosystem in Africa, and I'm going to summarize some of the results. So these are the co-investigators involved in this study. So just a bit of background around vaccine decision-making. We know that it's very important, and as Ben alluded in the morning, it's key in terms of it's key in terms of vaccine introduction in different countries. But we find ourselves in a situation where we need to prioritize vaccines, firstly, because we don't have the costs, and secondly, because not all vaccines are relevant in our context. But even when we talk about vaccine introduction, it's not just prioritizing vaccines, it's also looking at other competing health interests, which may influence, for example, the budget available for us to introduce vaccines. There are many stakeholders involved in vaccine decision-making, and both some are internal to the country and others are external or global partners. And in all of this, NITAGs are quite key, especially Ben has pointed out that there's been a flurry of NITAGs being created and established in the last few years in the African continent. So they are key. And they especially play an important role when it comes to evidence to recommendations of vaccines. And of course, we need to know what we're implementing for. So surveillance of vaccine preventable diseases becomes very important. And this obviously is driven by data availability as well data, which helps with data-driven decision-making. So the aim of this study was to describe the vaccine decision-making ecosystem in Namibia, Botswana, Eswatini, and South Africa. So our methods, what we did is interviews. We recruited stakeholders from 4 major groups, which are the NITAGs, the assistant partners, the Ministry of Health, namely EPI managers, and the Ministry of Finance representatives. And the interviews were semi-structured with an interview guide. They were an hour long, and they were on MS Teams. They were recorded and subscribed. So the results, 3 countries ended up participating because Eswatini declined to participate or were non-responsive. And of the people who responded, we had 8 respondents from NITAGs, WHO, and EPI managers. Unfortunately, there were no Ministry of Finance representatives. So what were the findings in terms of the different components of the study? So when we looked at priorities, we found that there were other competing priorities, as mentioned, that affected vaccine introduction or selection in the country. And some of them were health related. So one of the countries mentioned the COVID-19 pandemic and how relocating resources to that affected the vaccine programs. But there were other competing interests in different countries, such as national disasters, such as floods and drought, as well as conflict and humanitarian crisis. And these were sometimes specific to the region. What about vaccine preventable diseases as a priority? So we wanted to find out if there were specific diseases that were priority, and respondents told us that some of the respondents mentioned that vaccine preventable diseases, all of the ones in the API were important, but there were other participants who mentioned certain conditions such as polio, measles, and rotavirus, mostly because they have frequent outbreaks or because neighboring countries pose a risk. So the stakeholders who are both global and internationally. So when we tried to find out who the participants thought the important stakeholders were, NITAGs were mentioned specifically for their evidence-based recommendations, which in this study, NITAGs had adopted, had a recent recommendation adopted. But there was also the critique that NITAGs needed support for the role that they play in terms of secretariat and resources being made available. Another important stakeholder mentioned was the Ministry of Health, obviously who are key, as we know, but in this study, they were seen as being important for motivation of funding, final decision-making, and implementation of the vaccine decision. The Ministry of Health was seen important in terms of finding the budget. But what was interesting is that there were also other ministries that were seen to be important that required intersectoral collaboration, such as the Ministry of Education and the family sector, in order for vaccines to be implemented and to once vaccine influence vaccine decision making. We also had international partners or global partners. So the assistant partners, WHO and UNICEF, were seen mostly as providing logistical support to the country by the provision of experts as well as part of technical working groups. And SAGE recommendations were seen to be triggers to vaccine decision-making recommendations in the country. In the study, all the countries were self-financed, but it was acknowledged that Gavi does support some countries in lower income, specifically with some middle income countries also receiving financing. And pharmaceutical company was seen as important in terms of registration of the vaccine with a local drug and council, as well as providing different bodies with information about the vaccine product. So what was the process? It was quite straightforward. Evidence to recommendation was requested by the Ministry of Health. And then the NITAG deliberated this and made a recommendation. And then after the Ministry of Health took on that, made a decision depending on the recommendation and whether they thought it was appropriate. And then implementation was done by the API team. There were different factors that were involved, and some of them are on the slide. So vaccine safety and effectiveness was seen as important. In terms of availability of vaccines in the country, vaccine efficacy was seen to be important. And if a vaccine met the efficacy criteria, then cost became a consideration in the factor of vaccines. Recommendation, as mentioned, NITAGs would make the recommendations and government would adopt them. But WHO and SAGE were seen to be triggers to bring about a deliberation and discussion about vaccine. This wasn't in all the cases, but this was mentioned and highlighted as a factor. Political landscape, high political will. Countries with high political will was seen as a factor. There was issues around change of leadership affecting decision-making. So where you have a change in leadership in the immunization plan or in the health system, reprioritizing and changing priorities around vaccines or health in general. And there was also the issue of a lack of background of some of the politicians in immunization. And this is talking more about the managers of the immunization programs that would be affected. So target populations, mother and children, were seen to be an important target population, but specifically mentioned was the HIV population, the HIV infected people, because in these countries, HIV was actually a high burden. And so it was important. And then the health system impact. There were many issues, well, quite a few people who mentioned that you have an increasing number of vaccines with the same number of staff. And so it was seen to affect in terms of workload of the staff. And then obviously, what was the cost benefit in terms of impact on the health system? So what were the facilitators in terms of vaccine decision-making? So supportive legislation was seen as being critical. Countries mentioned, or one country mentioned, that it was important and it was enshrined in the Constitution, the right to health. And so that created a framework to promote vaccines and vaccine decision-making. The presence of strong local data. So in some of these countries, local research was being done by the universities. For example, I mentioned in the HIV/AIDS burden, and because it had context unique research on that, it became a catalyst and helped to influence vaccine decision-making. A strong EPI program with strong management and universal also was a facilitator of vaccine decision making. And there's mention of the university playing a role in policy development and policy making. As having been mentioned repeatedly in this conference, local manufacturing was a facilitator. So one of the challenges that countries faced, or one country faced, was they would make a decision to introduce the vaccine, but they would have to wait to have it introduced in the next 1 or 2 years, simply because the vaccine was not available. And so the idea that local vaccine manufacturing in Africa could aid and avoid this program. And it was identified that Africa is quite a huge market, and that if investment is made in Africa, Africa will be able to produce vaccines for local use. Other facilitators were around communication and coordination. So this was between both global and local partners and amongst immunization stakeholders. And what was found to be important is ongoing communication, not just at the time of vaccine introduction, but in between. The role of the community was seen to be quite important because they could use their rights to demand vaccines to be given to them as a right to health, mentioned as enshrined in the Constitution, as well as becoming center in the vaccine decision-making process. Another facilitator was vaccine access. So I've mentioned the affordability of the vaccines, as well as equity of the vaccines. And a final facilitator was advocacy. So healthcare workers to advocate for vaccine use in the communities, as well as other partners who advocated. So, we had one of the assistant partners tell us that their role was to advocate to the NITAG the introduction of vaccines. But there were considerable barriers, some of which vaccine registration was important. So if a country decided that they wanted to introduce a certain vaccine, but it was not registered in their country with the Drug Council, it was a problem. And also new vaccines being developed, such as RSV, not yet being registered, also restricts the ability of the country to implement a vaccine decision. Vaccine hesitancy was also being seen to be a barrier, especially now with access to technology. Basically, everyone owns a smartphone, and social platforms being used to perpetuate misinformation, and that will be discussed later on by other speakers. Human resources I've already alluded to, but also what was highlighted here was the lack of training that happens in the undergraduate system. So people get some training in the postgraduate, but not all cadres get training in the undergraduate system, which they thought would be important. And finances. So these countries were self-financing, but the cost of vaccine was still seen to be a barrier, which resulted sometimes in failure to implement or adopt recommendations by the NITAG. I've mentioned that surveillance is quite important because you need data-driven decision-making. Local data was available in some countries, but most of these countries used data from neighboring countries to make their recommendations or to base their recommendations on. There was awareness of several components of surveillance, but surveillance was not really well known amongst this cohort of people. But what was interesting is the use of shared resources such as laboratory networks. And then funding. The funding for these surveillance programs were government funding, and they were not quite well funded, but there is discussion of catalyst funding for specific programs. So just in terms of discussion, so the priorities we noted were factors beyond the control and the planning of the Ministry of Health. The stakeholders, what was interesting in terms of the government ministries was the intersectoral collaboration of other ministries, such as the Ministry of Education, the Ministry of Gender, the Ministry of Family Sector, as being important in playing a role as important stakeholders. The role of NITAG, even though highlighted positively in the study and in this and in other forums and settings, was seen to be important, but in other studies and in other parts of the world, the role of NITAGs was undermined by players within the health system, and they were also seen to be non-integrated, even though we know that they need to be independent. But what the participants were saying, that they were not integrated, and therefore they did not have an influence that they should in terms of vaccine decision-making. The pharmaceutical industry in the study played a positive role. However, there are other settings where the pharmaceutical industry has been seen to play quite a negative role with soliciting or influencing vaccine product selection in the various countries. The World Health Organization can play a positive role, such as in the study. However, when it comes to country prioritization, sometimes there is a conflict between what the country believes should be implemented as opposed to what the global community believes should be implemented. And then, of course, I mentioned the role of universities, who not only need to be involved in postgraduate, but also undergraduate education in terms of vaccinology. The issue around finance is not a big problem for this cohort because they were self-financing, but sustainability of financing becomes important in terms of priorities in lower middle income. And vaccine equity, as I mentioned, it also becomes important. So is a vaccine available, for example, for HIV positive people? This is also has also been an issue with HPV and other vaccines globally. As I mentioned, local manufacturing. So there are not many local manufacturers in Africa, but the numbers are increasing. And in fact, there's been a drive by the CDC and other bodies and entities, and I'm sure you've heard, to expand vaccine decision-making in Africa. And as we speak, the sites are increasing, and also what they can do at the sites is increasing. Vaccine hesitancy has become widespread, and there are strategies to try and mitigate it, and that's what we need to deliberate. Sometimes vaccine hesitancy also occurs in healthcare workers who should actually be advocating for vaccines, and of course in religious workers, religious people whom we are quite aware of. So the question is, how do we have a strategy to, in the minimum, at least target healthcare workers so that they promote vaccines as opposed to inhibit them? And then the surveillance system was quite fragmented, and what is needed is funding from ring-fenced funding from the country, and maybe in certain situations from global agencies to help give us data for data-driven decision-making. Thank you.
Thank you. Thank you very much. That was quite interesting findings. I'm sure there will be many, many questions. But for now, it's my pleasure and honor to invite Elizabeth, who give us the final case study focusing on the switch of the measles vaccine presentation, looking at the impact, experience, and cost effectiveness, and the lessons learned. So Elizabeth, 20 minutes.
Thanks, Jason. I'm very nervous, so please, if you can just keep silent your buzzer. So good morning once again, everybody. And I'll try and tell you a story because it's an unfolding story. In the next, I'll try and make it 15. So please excuse my nervousness. I'm very nervous. That's my disclaimer. So I'll be telling you the story about an ongoing study, the measles containing vaccine presentation switches, its impact, experiences, and cost effectiveness, and lessons that will be learned because the study is still in progress. I'll try and tell my story in 3 broad sections: the background, the ongoing study, and the novel contribution of VACFA niche to the existing body of literature and knowledge on MCV vaccine switches. So background and introduction. So we know for a chocolate that will be delivered, who can tell me what happened in 1974? Oh, come on. Thank you. But because you didn't raise your hand, I couldn't identify you. So there goes the chocolate. So in the past, measles was a killer that was almost killed. We wrestled it to the ground. But in the present, we see it as a defiant problem. Persistently low coverage, missed opportunities for vaccination wastages, and all this, collectively contributes to intermittent global outbreak. And of course, we know the effect of the pandemic on the national immunization programs. And very interestingly, anti-vaxxers in power, that's fake news. And we know where that is coming from. So there is a problem. So this very wordy slide is just to tell you that the problem of measles outbreak is global, it is regional, it is particularly devastating in LMICs, of which most of sub-Saharan countries belong to. And, but interestingly and importantly, it's been estimated that if all Gavi eligible, most of which are also in sub-Saharan Africa, if all Gavi eligible countries switch to using the 5-dose vials for routine immunization, at least 2 million additional children could be reached, burden of disease lightened, morbidity prevented, and on and on we'll go. So if there is a problem, then what are the solutions? An initial research conducted in Zambia found out that switching from 10-dose vial to 5-dose vial increases both doses of vaccine containing measles containing vaccines, no vaccine containing measles. It reduces wastages and has a positive influence and impact on healthcare workers' attitude. But in addition to this primary research, more data is required. And the need for this more data necessitates that high quality real world evidence be made available to countries. So how do we go about that? That was what prompted Gavi to put out this call in 2024. The call, as you can see, was issued on the 22nd of January. We got to hear about it probably the last week of January. So while majority of you were busy, enjoying flowers and chocolates during Valentine, my boss, Ben, and I standing on his shoulders, being supported, ably supported by two beautiful ladies, Alana and Chantal, we are working very hard. And out of that hard work was born this consortium. You can see that VACFA was the lead partner, ably supported by Linksbridge based in Seattle, US, and NSARS, they are called, in Australia. Imagine the time zones, imagine trying to have a meeting, across 3 continents. So that concludes the first part of my story. And then now the real core of the story, the ongoing MCV study. I'll try and put it in a nutshell, but I promise you a nutshell is too small to contain the ongoing story. So what is the aim of our study that this 3 consortium came together to pull together? The aim of the study is to conduct a comprehensive impact assessment on the switch from MCV 10-dose vial to the 5-dose vial presentation prospectively in Ethiopia. And as we speak, Ethiopia is currently introducing the 5-dose vials, and retrospectively in the country of Zambia that is supposed to have introduced it as far back as 2022. We anticipate observing a 10% increase in coverage for both doses of MCVs and in the worst performing district, and at least a 5% increase nationally where applicable. Our study has 4 objectives. I just wanted to put up that slide to show you, to convince you that we do have objectives. And objective 1 is the primary objective, and the first research objective, the first research question there is our primary research questions that we use to calculate our sample size and what have you. And then objective 1 is mainly quantitative in nature, as you have seen, and this becomes important when we breeze through the study methodology. Objective 2 is a CAP study, both for healthcare workers and caregivers. Objective 3 is where we will zero in on the real world economic impact aspect of the study. And it's a mixed pot of both quantity and quality research methods. And objective 4 is a bit of an outlier. It's my favorite, probably because I'm working on it. And to that effect, I would like to speak to the gentleman from Uganda and to the beautiful lady also from Botswana. Please, it's tea time, we need to have a chat. So over time, the overview of the study methodology. So objectives 1 and 2, objectives 1 and 3, will employ or has employed an integrated mixed methodology approach, which, involves pulling of items from various tools. And I will show you a couple of examples soon, into questionnaires that are loaded on, in the REDCap database. The REDCap database itself is loaded on electronic tablets. Objective 2, which is basically qualitative, consists of in-depth interviews conducted with those two group of stakeholders. And objective 4 is a light touch. I'm hearing that from Gavi for the very first time, landscape analysis, and it employs both a combination of literature review and primary studies. And the primary study consists of in-depth interview with relevant stakeholders that are listed there. So these are some of the examples of existing tools that we pulled items from and adapted those items to suit the study country's context. Remember, Ethiopia is prospective and Zambia is retrospective. We are conducting a retrospective study in Zambia and a prospective one. So we pulled questions or items from these tools and others. The best tool, I didn't show them, and loaded it on REDCap for our data collectors who went into the field. And this is just to show you a screenshot of what the REDCap survey, for records for caregiver looks like from Zambia. And some of the data captured already. This is to show the gender distribution across the 4 provinces that we are working in Zambia. And I came to understand that Zambia has a very interesting policy that if a male partner accompanies his pregnant partner to antenatal care or takes a child for vaccination, they are allowed to bypass the queue. It doesn't matter how many women with children. That, they say, is to encourage male participation. But I wonder what it does on gender equity. And this is just to show the integrated tool for costing that were loaded onto the REDCap survey, and some of the data captured. This just shows the distribution of the 3 kinds of facilities that we worked in: the urban, the peri-urban, and the rural. And Ethiopia is not left out, and you can see that the screenshot of their database is somewhat similar, but actually different. Time will not permit us to tease that out, but when the study is concluded, we will be able to see that. And this is just another example from Ethiopia. And for this, now I'm sure, I just want to illustrate something. This is baseline. Remember, the study is still ongoing, analysis is still ongoing, but note that the coverage, for both administrative coverage, the reported administrative coverage, and the household survey coverage that the study team did, 75%, 72, 74, 68. Now, that is the baseline. We are hoping that at the end of the study, we will be able to detect that 10% increase that we want. But this coverage is suboptimal, yes or no? Quickly, time is running. Is it optimal or suboptimal? Why so? it should be 100% coverage, but we know it's not. So for a chocolate, who knows the herd immunity threshold of measles coverage? All right, clap for yourselves, everybody. That's the best chocolate you can get. All right, so emerging qualitative insights, example from Zambia. So the knowledge of the caregivers shows that although most caregivers could not tell you, oh, my child received a measles containing vaccine like you, educated lot, will be able to. They could, however, articulate where on the body it is injected and when it's given. If I have more time, I would have asked you where on the body is MCV1 given and MCV2 given, and what are the time, what are the different times? The attitude, there was no considerable attitude yet. Remember, this data is still under analysis. So these are just initial, so it could be proven to be otherwise. And then knowledge of healthcare workers, unlike the caregivers, healthcare workers were very much aware that there had been a switch, although they were not always certain, then the communication efforts, these are things that are emerging, we need to work hard, better on that. And, let me just race through. Then the attitudes of the healthcare workers, there was, enthusiasm to receive the 5-dose the 5-dose vials, and the fear of wasting doses significantly reduced from what the data emerging from Zambia is telling us. And then the practices of the healthcare workers is a mixed bag, even though there was a positive, attitude because they eagerly use the 5-dose. They are not explaining to the caregivers what is all about, kind of puts a damper on that. So also, let me just speak to objective for the outliers. The literature review showed that there is no documented evidence of the process of a formalized linkage between a NITAG and an academic institution or academic institutions. And we had the gentleman from Uganda talk about the challenges that they are having. And most of my respondents is that they also highlighted the same issues, and they are recommending a strong relationship, a formalized relationship or a structured relationship between NITAGs and academic institution. So the last part of my story, in addition to all that is expected of us, our agility demands that we add an extra chocolate to what Gavi requested from us. And our journey map is our novel value add to the RFP, because it wasn't required in the RFP. We threw that in ourselves. So what is a journey map? A journey map can be described as a tool used to visualize and understand the steps and interactions involved in a particular process from the perspective of those involved, given a clear understanding of their action towards achieving their final goal. I'm sure it's somewhat distantly related to the heuristic that Julia spoke about earlier. It allows for the translation of their insight into intelligible visual formats for decision-making in various scenarios. Just hold your heart, we'll soon see what it looks like. In our study, what is a journey map in the study? So in the MCV study, it is an end-to-end visualization of the entire switching journey from 10-dose vial to 5-dose vial for the decision-making process through the implementation and impact assessment. Ladies and gentlemen, this is what a journey map looks like. But this particular one is based on assumption As the story unfolds, it will be amended to reflect the actual study country's reality. So how do we intend to go about that? We have the Excel spreadsheet to collect the appropriate data that we will now use to populate the journey map, and maybe eventually put in some infographics, or those little pictographic, whatever you call it, and make it more accessible. So what is the use case if we have a journey map? It's to ensure that every actor within the health system is aligned, because when you can see where you are going and who you are traveling with, you will be able to help them, and both of you will successfully get to your destination. To also understand what happens along the way at all touch points and across the health systems, and to help countries that are contemplating the switch to optimize their strategies and create a seamless switching process strategies. So emerging notables, because we can't conclude on a story that is still unfolding, but there are some very, very salient points that are coming out. And the first one I'll just mention is that the switch is highly recommended. So if you are here from a country that is yet to make the switch or make the recommendation, please, it comes very highly recommended. I'd like to acknowledge the Lord God Almighty, the invisible one, so you won't see him on the list, but all these gentlemen and ladies that you do see on the list helped in one way or the other to help put the story together. Thank you all for your attention, and happy to take questions. Thank you.
Thank you very much, Elizabeth. That was quite interesting. You can just stay on stage.
Oh, I thought there was no question.
There are a lot of questions, I'm sure. And we also have representatives from Ethiopia, from Zambia, from the other countries where these case studies were done. So we'd also ask if you could comment or provide some additional information. So let me invite the other two ladies. Where's Julia? Is she still here? Okay, yes. And Nina, please, if you can come to the stage. I'm sure there will be a lot of questions. Okay, who can help? There's another mic somewhere. Oh, is there the mic? Oh, yeah, okay. And then also the online participants. So let's start. Yes, please.
Thank you. I appreciate all the three presentations. Very nice. Well done. But allow me to narrow it down to the MCV, the presentation just concluded. What was the impact on the cold chain? I would really like to know.
Very minimal from the data emerging from Zambia. Ethiopia is still in the process, so we don't have any data emerging from there yet.
Thank you.
Thank you very much. Yes, please.
Thank you very much for those presentations. My question is about the critical systems heuristics approach. I think it's very interesting and very inclusive. I'm wondering though, how does that model handle conflicting perspectives? Because is every perspective valued or weighted equally if the goal is not to have one viewpoint?
Yes, so the idea is to make it as transdisciplinary as possible and to examine the decision making. So each viewpoint should be valued the same, so that all the viewpoints will be taken into consideration when looking at the decisions. But of course, if we see that there's similar themes arising more times, that's just a kind of a knowledge that is just kind of coming up more times quantity-wise. But in theory, all the viewpoints should be taken into consideration.
Thank you very much. That's the end of the room.
Thank you. My question is also about the critical systems heuristics and about specifically about the causal loop diagrams. I saw that there weren't any how do you call it, balancing feedback loops, like the negative feedback loops. Is that because the focus was specifically on success factors? Were there any inhibiting factors or barriers that came up during the analysis? Thank you.
Yeah, thank you. Yeah, so maybe this specific causal loop diagram was then a bit biased. There were also a negative feedback loops, but for this time I only had time to show in one example, and it was from this. Yeah, thank you.
Thank you. My question also goes to Julia. I was thinking of if there is any difference between the critical heuristic system and the classical one, with maximum variation. So the qualitative study with a maximum variation in sampling and all the things like that. So I couldn't see if I was thinking if there is any difference or if it's just the philosophical assumption is the same.
I'm not sure if I can properly answer this, but yes, this is more based on these 6 boundary categories that are modified for the specific study, which was on the transformation and those, and then also combining that with the multiple perspective tools. I'm not so familiar with the other framework you mentioned, but this should be just using these different tools to understand the decision making and the power dynamics as best as possible.
Thanks to all the speakers, but the question is to Elizabeth. What do you think about other vaccines? So the multi-dose, hexavalent or pentavalent vaccines. Are you considering looking at that, or do you think it's going to be similar to the MCV switch?
Yes, we actually considered that in the proposal, but the timelines to conclude the study are so tight, we could barely even analyze MCV, not to talk of looking at the impact of it, especially on other second life vaccines, which we would have loved to do had we more time.
So we have 2 questions and 1 comment.
Online? Yeah, okay.
Yeah, online. So the comment is to something that you mentioned, Dr. Elizabeth, on the fact that in Zambia, if a man comes for vaccination, they are passed up. So a few people have also commented that this is the case in their countries, and that is Ghana and Gambia as well. So it's interesting. And then we have a question from Dr. Sambo. He's saying, excellent presentation. And he's saying, considering that your study is still ongoing and based on the excellent preliminary findings that you have so far, could you predict whether switching from the 10-dose to the 5-dose vial might be sufficient to enhance vaccine acceptability and service delivery, thereby contributing to improved measles vaccination coverage towards the target levels? And his last question there is, what should be the success factor then if that's not the case?
I want to thank that person. I didn't quite get the name for
Dr.
the
Sambo.
Dr. Sambo. All right. So as to his first question, switching from 10-dose to 5-dose alone is not sufficient in itself to increase coverage, but it can make a significant impact, as the pilot study in both Zambia and Ethiopia had shown. And I did mention it, it increases coverage, reduces wastage, and much more importantly, has an impact on healthcare workers' reluctance to open a dose, to open a vial when desired number of children is not present. But it needs to be accompanied with other interventions, other forms of health system strengthening. Let's not just say, oh, we have switched from 10 to 5. Now we expect our coverage to go through the roof. It doesn't work like that. And what was the second question? Could you remind me quickly?
Second question was, what should be the success factor then? What would, I guess, improve uptake if switching is not?
Yes, switching is not the silver bullet, right? But and the impact of the switch needs a time lapse for us to actually be able to detect and to be able to say, oh, this is the success factor that the erstwhile 75% coverage of MCV1 in Ethiopia, as shown in the baseline data, now had gone to 85 or 90. So for that, it's a bit tricky to nail down one thing, because remember, it's a system and we have different moving parts all working together to achieve that goal. And that question also will be answered at the end of the study when our journey map is complete. And then we can now point to things that, okay, at this point, this was the success factor, or at that point, that was the success factor. Thank you.
Okay.
One more?
Yeah,
Okay.
we have one last question for Julia. But I just want to say, Gina, you didn't get questions because after your presentation, everyone was commenting, excellent, excellent. I think they understood everything. So the question to Julia is, how easily available is the M72 vaccine? And then they're just commenting that despite the 50% success rate, I think that was mentioned by Tom the other day, Cornelius thinks it's a huge impact. It will be a huge impact on TB reduction in our setting.
Yeah, thank you. Yeah, for sure. How available the vaccine will be, I think no one knows at the moment. It depends on multiple different factors. The vaccine is still in a clinical trial. Hopefully it will be successful. If not M72, then hopefully another similar TB vaccine. But yeah, the availability will depend on multiple different factors, which will be about the adjuvant that is owned by the GSK, about how many vaccines will be manufactured, how many can be rolled out, where it can be rolled out. So I think these are the questions that we try to look into when we think about the implementation of the vaccine, to make sure that we are prepared when the vaccine will be available and how it can be distributed as many people as efficiently as possible. Yeah, thank you.
Thank you very much. Any other comment? Okay. Maybe a question for Gina. You mentioned that Eswatini declined to participate in the study. What was the reason for that?
So it wasn't really decline. It was what we call non-responsiveness. Despite multiple times we did make initial contact and they did respond, but the follow-up, they didn't respond to the follow-up. So I'm not sure why that happened. I don't know if it had to do with I think maybe they were busy. They were introducing the HPV vaccine and a lot was going on. So that's the only thing I can surmise.
Thank you. Maybe another question also. I saw that there was a request for local data, but then you also mentioned that the surveillance was fragmented. So how do you sort of manage that situation where the NITAG or the policymakers want to look at the local data and it's not available because the surveillance is not of good quality to provide that data that is required for decision making?
Thank you. So I think there are two ways you can address that. And I think it links up to what Elizabeth was saying in terms of building a relationship or structuring a relationship between NITAGs and an academic institutions, because often the academic institutions will do research which can use to make data-driven decisions. And for example, this happened in one of the countries with the HIV burden, where the studies for that introduction of the vaccine was done in-house and was done in context. So when it came to making the decision about the introduction of the vaccine and the impact on the population, the data was available. So that's one aspect I see it as really trying to engage with that issue. But the surveillance system itself seems to be quite, I know WHO has published guidelines and how to do surveillance. And I think the solution to that is that there's no focus on funding surveillance. So there's focus in funding vaccines. There's focus on different aspects of immunization, but there really isn't focus on surveillance and funding surveillance and making sure it's up and working. And I think that's the challenge, is to get surveillance as a priority on the list of people who make decisions around vaccines, and not to be seen as, oh, by the way. So I think increasing funding and ring fencing funding for surveillance is very important, especially because, and I'm not talking about as an international, I'm talking about as a government in-house, in-country, maybe with support of global partners, but yes.
Thank you very much. Any other comment from the audience? No? Oh, where's Ben? Oh, Ben. The stage. Can you come to the stage? So Ben is the team lead. And one of the things that you notice is that the PIs of these 3 case studies were ladies. So Ben, congratulations. This is, I think we talked about women empowerment. So congratulations, Ben. And congratulations to the 3 ladies. I think this is really excellent stuff. Thank you very much. Hmm?
Stuart and Gina,
Oh, yes.
the PI.
Right. And Ben, that was really excellent. Thank you very much. And I hope everyone now knows about the NITACs niche and how niche is supporting and empowering the NITACs to make sure that they support the ministries of health to make the right decisions about the vaccine introduction, optimization, and prioritization. So Ben and your team, excellent stuff. Thank you very much. I think it was really good. And to the audience, I think you need to clap for yourselves. It was very interactive, but enjoyed. I think there were many more questions, but for now, I think we'll break because it's time to take a health break for 10 minutes. We come back at 10:30. I don't know if there are any admin announcements. I see health break and photography session. Are you going to have another photography session or just a health break?
Can I make a quick?
Yeah, sure.
This is a request. So when we are responding to Gavi's RFP, if you look at the weighting, and remember this is global competition, one of the success factors was ability to work with different stakeholders on the continent. And we've trained almost 1,200 people from Africa. So we hope this relationship does not end today. We can partner in responding to such RFP, because this is how we can generate evidence that is going to help us in decision making. So if you want to be part of collaborative effort with us, we have the view that we can only change what is happening if we work together. So please reach out to us, and also we'll be reaching out to you. So when you see our emails, don't ignore it. It's about trying to work together, generate evidence to help us move forward. All right. Thank you very much.
So thank you very much. That was really wonderful, very informative. So we take a health break for 30 minutes. Thank you very much. See you soon.
Hello. Hello, everyone.
Hi.
Welcome back, everyone. Our next speaker is Professor Hanneli Meyer, and she will be talking on vaccine confidence, strategy to improve vaccine decision-making and demand generation in Africa. Over to you, Professor Hanneli.
Thank you very much. There's an echo. Still an echo. Must I get away from the... Hmm? Oh, you can't hear it. Is it better? Okay. All right. Let me stand away from the other mic in any case. So thank you very much for inviting me here again to this fantastic course. And yes, so I'm very excited about this topic. And this is why, is this thing working now? Okay, there you go. All right, so this is my declarations of interest. So my main declaration is that I'm very passionate about vaccines to save lives. And the other declaration is I have too many slides. So I am going to fly through some of them, but they will be there for you to look at. And yeah, so that is my declarations. So I always start with this slide, which says that or shows us how fantastic vaccines are, how successful they are. And you've heard it over the last couple of days. So as we are standing here, each and every minute, 6 lives are saved. And this is all thanks to vaccination. And that's been going on for the last 50 years. But what are we seeing in the media? And this is all over the world. So it's not only in Africa, not only in South Africa. This is all over the world. We are seeing all these vaccine preventable disease outbreaks. And my question is, if you look there where the question mark is, why are we seeing vaccine preventable disease outbreaks amongst healthcare workers? Okay. So we've spoken, many speakers actually spoke about Immunization Agenda 2030. And for us to achieve this agenda, this article was published in the Lancet quite recently, and it highlights that we need to strengthen primary health care because this is where people access their medicines and their healthcare services. We need to address vaccine misinformation. So Adele is also going to speak about that. We need to address vaccine hesitancy, and we need to adapt to the local context. Okay, so we've been talking about these things for years, I can almost say, but now the Lancet has actually pointed out these very important issues. So the question is now, why are we seeing low coverage? Why are we seeing vaccine preventable disease outbreaks? So I want us to take a step back first. So in 2019, the World Health Organization declared vaccine hesitancy as one of the top 10 threats to global public health. And little did we know but that by the end of that year, we are going to be faced with the COVID-19 virus and then the declaration of the pandemic early in 2021. So when this happened, a lot of people actually was like raising their eyebrows, vaccine hesitancy, what is that? How is that possible? Some of the scientists actually said, no. This COVID-19 vaccine will take care of vaccine hesitancy because everybody is going to run to take the COVID-19 vaccine. So where did this whole opposition to vaccination start? So some other speakers also mentioned it earlier this week. So it already started years and years and years ago with the cowpox vaccine, where people, as you can see in that picture, said it is unnatural, it's ungodly, and when you get this vaccine, you're going to grow horns, you're going to look like a cow, and so on. But this was a terrible disease, and it killed so many people. Millions of people were killed. And then in 1980, there was global eradication of smallpox, again, thanks to vaccination. So then people started building confidence in vaccines, more vaccines were introduced, and if this thing is making a noise, yeah. More vaccines were introduced, and people could actually see that, vaccine preventable diseases are going down as people get vaccinated. But then in 1998, Andrew Wakefield published this paper in the Lancet, which is the most prestigious journal. As I stand further away, I can. This thing doesn't like me here today. Must I move there? Is it fine? Okay. So Andrew Wakefield published this paper in the Lancet, one of the most prestigious journals in science. And he said that the measles vaccine is responsible for causing autism in children. And the problem was that his study was completely unscientific. As you can see there, believe it or not, he only had 12 children in his study, and he had no control group. And someone else actually, I think it was Mike, actually also showed that you need to have a 2x2 table to illustrate or to assign causality or determine causality. So he only studied 12 children. He had no comparison group. He made false claims. He claimed an association, and there was absolutely no scientific basis for what he was saying. So his paper was retracted from the Lancet, and he was removed from the medical register. But it took 12 years for this to happen. Only happened in 2010. So imagine all the damage being done over a period of 12 years, and we still see this damage today. So the question, are vaccines associated with autism? People will continue to ask that question. Whenever I go on a radio interview or wherever, there will be a question. But does this vaccine cause autism? Is it really not true? So there's been so many articles published providing evidence that the measles vaccine is not linked to autism, but still you see vaccine hesitancy persisting. So now also international spread of misinformation, and I would say disinformation as well. So these false claims and statements are being made, and that is undermining trust in vaccines, in governments, in the health authorities. And it all started, or it actually sort of got flamed again when Donald Trump appointed RFK Jr. in the United States as the health secretary. And you can see that on the right-hand side, which was published by the Pediatric Association in the US, where they were saying what's supposed to be a normal healthy child visit becomes now very complicated because they need to explain to parents, that these vaccines are safe. And so you need to start convincing them all over again. He also promised, as you probably know, that by September this year, they're going to find the real cause of autism. And then they actually announced it. I think it was, in September. They announced it, and thank goodness, it is now paracetamol. No, it's no longer vaccine. So I'm very happy about that. But nevertheless, who is RFK Jr. apart from being the health secretary in the US? So during the pandemic, they followed 50 something million people on social media, and they identified 12 people responsible for 65% of the misinformation spread on social media. And they published this report called the Disinformation Dozen. As you can see, some people even call them the Dirty Dozen, which I think is a more suitable description. But if you look at the people, you can actually go download, read the report. If you look at the list of people, guess who is number 2 on the list? So these people are anti-vaccine. They are vaccine skeptics. And now we have a vaccine skeptic in charge of health in the US. Okay, so I just want to distinguish between disinformation and misinformation. So misinformation is false or misleading information being spread. Disinformation is also, but it's being spread deliberately by people. Then you get fake news and you also get all these conspiracy theories. So there's a difference between all of them. But what it does, it creates negative perceptions in people's minds. So people become anxious, they become, they fear the vaccines, they refuse vaccination in the end. There's a decrease in confidence and there's a decrease in trust as well. So now, just to get everybody on the same page, what does it mean to be vaccine hesitant and what is driving vaccine hesitancy and who can be vaccine hesitant? So vaccine hesitancy is a very complex phenomenon. It differs by vaccine, by population. It differs over a period of time. So this, according to the WHO SAGE group, they said that vaccine hesitancy is the refusal or the acceptance of vaccination despite these vaccine services being available. So it could be the refusal, or sorry, not the acceptance, the refusal or the delay in acceptance of vaccines, despite the fact that we have vaccines available. And as I said, it can differ with regards to vaccination, people, time, place, and so on. Then Heidi Lawson published a paper where she actually said that now quite lately, actually vaccine hesitancy is just one word, and that is indecision. So people are not being able to make a decision whether to vaccinate or not to vaccinate. So she says that if you have already accepted vaccines, then you are no longer hesitant, or if you have already decided to refuse, you are no longer hesitant. Bearing in mind that that situation can change with time. So you could be hesitant towards the measles vaccine, but you will be prepared to take a tetanus vaccine or the yellow fever vaccine. So it's a very complex phenomenon. Now, who can be vaccine hesitant? Just about everybody. Okay, so someone asked earlier this week, who is vaccine hesitant in this room? So you can put up your hand if you like to now. But, as you can see, it could be anybody from, adolescents to elderly people, pregnant women. We go down to people in society, educators, religious leaders, celebrities. Just anybody could be vaccine hesitant. And what we need to bear in mind is that these people are influencers of other people's decision making. So that is why it is so important to be able to identify them. Now, something to remember is that a vaccine denier is not the same as somebody who is vaccine hesitant. So there's a guide published by the WHO, which you can also go and have a look at. There they explain very well what a vaccine denier is. But in essence, this is a person who does not believe in the science that we believe in. So they have their own pseudoscience. I mean, it doesn't exist, but they believe that is the science. And that is what they believe in. So I always advise people, do not try and argue with them, especially not, in open media, because you are not going to get anywhere. So they are few, like you have seen, the 12 responsible for 65%, but they are very loud. They're very loud. So people think there are so many of them, but the majority of people are actually on that hesitant spectrum. So with vaccine hesitancy, that's where we need to focus. We shouldn't be focusing on the anti-vaxxers. shouldn't be focusing on them. We should be focusing on these people who have concerns about getting a vaccine or not getting a vaccine. So those are the people that we need to put our energy into. So this was also published during the pandemic. So the question is, how do you move someone on that spectrum from not accepting a vaccine, to the point where they will be accepting a vaccine? And then another very useful report that I would like to recommend you go and read is this behavioral and social drivers of vaccination. So this is very useful. It contains questionnaires, guidelines, which you can actually adapt to your own practice. In addition to that, researchers identified as 5 main drivers of vaccine decision making. So I'm going to use these 5 drivers to take you through what are the problems and what should we or could we possibly do. So we were looking at, how can we build confidence? What are the missed opportunities? How to address people's concerns about vaccination? And what are the important considerations we need to take into account? So the first one is confidence. So confidence is all about trust, the trust in the vaccines, the trust in the people making the decisions about the vaccines, and also the healthcare services being provided. So we've seen, following the pandemic, and this is now in South Africa, but as you can see, there were many countries involved. Tony also referred to this report earlier this week. But we've seen in South Africa a 30% decline in confidence in childhood vaccination following the pandemic. So 62% of people indicated that they feel confident in childhood vaccines and that they will give their children all the recommended vaccines. But we've also seen it amongst adults. So this report came from a study conducted in, I think, 23 countries. And when one of the questions they asked adults was, are you willing to accept other vaccines? And as you can see there, on average, almost 40% of people were like unsure whether I'm now going to receive other vaccines like influenza, hepatitis B, and so forth. So it had an impact on childhood as well as adult vaccines. Now, this is the Edelman barometer. So what I want to show you, so bearing in mind, we've seen that 60% around it. So this comes from South Africa in the latest Edelman barometer, but the numbers are exactly the same for the global report. But as you can see there, only 63% of people were confident in childhood vaccination. But what is very disturbing is that only 55% of people in the age group 18 to 34, which is your childbearing age, only 55% of them actually indicated that they feel confident in childhood vaccines and that they will give all the childhood vaccines to their children. But I can also mention in other research that we have conducted, this very same age group are the ones being prepared to look for their own information, but they are not prepared to check the information. So they will look for information, and you know what you can find online, and they will just use that information and they won't check whether it's true or false. Then this is a study that was conducted by Imen and amongst pregnant women. I also just want to show you there that, again, can you see the same number, 66% of pregnant women, so this is in South Africa, feeling confident in acceptance of childhood vaccination, which is really a serious concern. Someone now pregnant at the moment. And then healthcare workers. So this was conducted, there's a number of studies conducted in South Africa, but just to point out, healthcare workers are also concerned about the safety of the vaccine, about the efficacy of the vaccine, how it was developed, about natural immunity. So I'll get back to that now as well. So my question is, are healthcare workers, bearing this in mind, are they able to convince their patients to take their vaccines? Okay, then misinformation and public trust. It's a threat to public health. So this was also recently published in the Lancet, and they pointed out that we really need to do something about this now because it is a serious threat to public health because of this whole trust issue. So if we look at the next driver, which is complacency, so this is now, do I consider the risk of the vaccine preventable disease, more, and therefore I'm going to take the vaccine, or do I consider the risk of the vaccine preventable disease not that important, and then I'm not going to take the vaccine? So during the pandemic in South Africa, we've seen that people were quite prepared to take the vaccine when it becomes available. It was almost like 75%. But in the end, 2 years later, when the vaccine was available, only not even 50% of adults got the COVID-19 vaccine in South Africa. And we had to write off, I don't know how many vaccines, but it was a lot. So the question is, how do you move people from that point of intention to vaccinate to putting that intention into behavior? What do you need to remove, to make that possible? So this was just a study amongst the elderly in South Africa, looking at whether they have received the influenza vaccine in the previous seasons. And as you can see there, only a third of them received the influenza vaccine. The reason was that it's not available to them, okay? The other one was the pneumococcal vaccine. So that was even worse, and that was lack of awareness. They didn't know about it. And someone also spoke about, the pneumococcal vaccine this week and how important it is, and especially for the elderly people. So they were not aware of it, and it was not available. Again, from immense study amongst pregnant women, they asked them, before pregnancy, were you prepared to get the COVID-19 vaccine during pregnancy? And Claire also spoke about vaccination in pregnancy yesterday. And as you can see there, only 4.4% of people were prepared. When it comes to the influenza, it was much higher, 48%. But still, it should be 100%. It shouldn't be just 48%. So what are the reasons for these kind of decision making? Then the next driver is constraints or convenience. So it is, am I able to get the vaccine? Can I get to the point? Do I have the money? And so on and so on. Do I have the time? So what we have seen is, and this was published quite recently here in South Africa. It's not a scientific article, but they looked at what's happening in some of the provinces. And I just used two examples from there. So this is Nosandile. She's a hawker from a rural area. She looks after her two grandchildren who are orphaned. And she lives, they're 9 and 6 years old. She lives in a rural area, and the closest facility for her health facility is 10 kilometers away. So what did she say? And she was pro-vaccination. She said, I often have to rely on relatives to take these children because I need to tend to my little shop. I spend a fortune on money to get to the facility, and then there are long lines. I wake up in the early hours of the morning and only return home in the afternoon. So then the shop will not be operational on that day. The lines are so long that sometimes the nurses tell us to come back on another day. And then she said, we face problems in these rural areas compared to people in urban areas. And this one is Sereko. She is a mother of a 2-year-old girl. And what did she say? She also said, I recall visiting the clinic 3 times, yet my child remained unvaccinated. From the time she was born, she has not received any vaccination, and she's 2 years old. Whenever I visited the clinic, she was facing all these problems of stockouts, long lines, and so on. And then she said, my frustration lies in the fact that this little girl will now lack any protection without any vaccination. So although we have, like Rudzani mentioned, on this side, you have high vaccination uptake. On the other side, you have low vaccination uptake. So we need to consider the context when we are looking at, why people are not vaccinated. Why do we have zero-dose children? Then we also saw during the pandemic, this was an issue about literacy. So during the pandemic, we were all very excited. We had an electronic system where everybody could book for appointments, the first time in South Africa. But the problem was with these elderly people in more rural areas. Some of them didn't have the right phones. They couldn't make the appointment. They didn't understand it. Some of them couldn't read. So there were lots of issues because we rolled out to the elderly first. But then these people couldn't come for their appointments. They couldn't make the appointments until the government realized what was going on. And what was going on, and then they had made plans, and all NGOs got together and they went into the communities to get these people to the facilities. So a further study that we have also conducted just confirmed that even the normal adult out there, health literacy is a very difficult issue. And although people are literate, when it comes to health and when it comes to vaccines, it is very difficult. So there are lots of issues. So you can see about 30 to 40% of people needed help when reading vaccine information. So when it comes to calculation, this is now all about, weighing the risks against the benefits. And that's one of the most difficult concepts for people to understand. So what people's main questions is, does the vaccine really work? Is it safe for me and my baby? Is it safe for me? I have maybe comorbidities, or I'm already old. Is it really safe for me to take vaccination? And this study has shown in Africa, it was a modeling study, but it has shown that these are exactly the things that people are concerned about. Is it effective? Is it safe? And is it really important for children? Then this was also part of a small study that we conducted, but I just want to point out there in red, 62% of the people said vaccines can cause autism. 64%, they were very concerned about dangerous ingredients, side effects, and all those things. And the speed at which the COVID-19 vaccine was developed. So this was conducted after the COVID-19 pandemic. Then this is also, I got this also from Imen, thank you very much. So amongst her pregnant women study, I just want to show you that after they have explained to people what whooping cough is and the importance of vaccination, because people wouldn't know. So they informed them first, and then they would ask them, so if the vaccine is available to you, will you take the vaccine? Again, 66% were hesitant. Only 33% was willing to take the vaccine. And exactly the same happened with the RSV vaccine. After explaining to them, oh, sorry, about, 63%, that's correct, and 30, so more or less the same. So only a third of them were willing to take the vaccine. So now we need to understand what people are looking at. So they're looking at what is the probability, or how likely will there be a side effect? And, should it happen, how serious will it be? So if they have, there's a perception of a high level of risk related to the vaccine side effects, they will not get vaccinated or let their children be vaccinated. On the other hand, when it's the other way around, they will then accept the vaccination, get their child vaccinated. But what's very important is that we must remember that the layperson, the patient out there, even highly educated people, they do not base their risk perception on a similar sort of platform than what we as scientists do. We base our risk perception on evidence, what we have studied, what we have learned, what is out there on facts and looking at the person that we need to vaccinate. Well, the public will base their risk perception on what they hear in social media, what the neighbor is saying, what my friend is saying, what my relative is saying. And then if there is poor health literacy, it becomes even more difficult. So the last one in terms of the drivers is collective responsibility. So this is all about herd immunity. Am I responsible for making sure that, you know, my child is vaccinated to protect the other children, for example, or the other people around us? And then I added antimicrobial resistance to this as well, because there was a very you know, volatile discussion, I would call, the other day on antimicrobial resistance. And I mean, it hasn't made its way yet into the drivers of vaccine hesitancy. But we all know what herd immunity is. But the anti-vaxxers, so there's often, you know, a huge misperception about herd immunity. And the anti-vaxxers will compare us who believe in herd immunity to sheep. No, herd immunity. So we are gullible, we just follow the leader, we are getting anxious, we're vulnerable to mob psychology. And then actually, this book was published, We Want Them Infected, by a medical doctor, where he said that in the beginning, even before the vaccines were available, there were epidemiologists and medical doctors who actually said, well, it's good, especially for children, to get infected, to build this herd immunity. And as you know, later on, there was huge discussions around it and at what percentage there will be herd immunity. As we know, 95% is necessary for measles. So this actually resulted in then more people following almost this anti-vax route in terms of herd immunity. And then with regards to antimicrobial resistance, that is going to be our next pandemic. So every now and again you would see it in the media. I'm telling you, AMR is going to be our next pandemic. Never mind what disease X or virus X or bacteria X. Antimicrobial resistance. And as you can see, purchasing of antibiotics over the counter happens a lot in many African countries. So we've done this sort of a review. And as you can see, there are many countries. And as I told you, we've just done a survey, and 40% of those patients purchased antibiotics without a prescription. So now what are we going to do about all of this? How are we going to build trust? How can we communicate? So what I want to point out, there's actually an ethical aspect of vaccine safety communication, which we need to bear in mind. And it's actually almost like a dilemma of public health. So how do we promote health of the population while respecting the individual's liberty and autonomy? And what is important, I mean, vaccination is an important pillar of public health, but we shouldn't be promoting vaccination almost like at all costs or blindly. We always need to be honest and bear in mind the, you know, the risks that are involved. So when we communicate about vaccine safety, it is very important that we ethically justify what we are saying. So transparency is extremely important. We need to base our fact on scientific evidence. We need to be transparent. We need to acknowledge that there is still uncertainty. There will always be uncertainty. And we need to acknowledge that and explain that, bearing in mind that we are facing people with low vaccine literacy. And they found that if we do that, we can actually build trust. Well, if we don't, we can increase vaccine hesitancy. So that is why it's so important to tell people they need to report adverse events following immunization. When do they need to report? Whenever they have a concern. Anything must be reported. You should never discourage, even if you think it's ridiculous, even if you think it's impossible, just let them report it, because you need to show them we are concerned about vaccine safety. We are concerned about you. We want to make sure that you are safe and your child is safe while taking the vaccines. Then just something on the use of illustration. So yeah, you can see, you can go and read the article, using an illustration to illustrate to people what are the risks of illness versus the vaccine side effects, because it's very difficult for them to understand it. After we had someone who died following the Janssen vaccine, this person developed Guillain-Barré syndrome and lots of complications eventually. Unfortunately, he died. On radio, people were, or the presenter actually asked me, so if I get vaccinated today, when will I get Guillain-Barré syndrome? It was like, I'm going to get Guillain-Barré, and when will I die? So they think if there's one adverse event, everybody is going to get it, and it's going to be very, very serious. So this is just something on formaldehyde, so I'm not going to go through all the text, but just to show you. And this is something that you can use for patients and people who don't understand. Just compare the percentage of formaldehyde in a pear compared to a vaccine. So if you have a pear, if you had a pear recently, you are now in trouble, no? The same with aluminum. So you're looking at, the amount of aluminum that babies would get in over the first 6 months of life is only 3 milligrams. Look at formula milk. Look at breast milk. So this is something that we need to explain to our patients, and you can use illustrations to do that. Now, on antimicrobial resistance, so what I mentioned also the other day in the discussion, it's actually almost like the flip side of the coin, because vaccine hesitancy and antimicrobial or antibiotic overuse, they exist side by side at the same time. Because people consider vaccines as dangerous, as hazardous, but they consider antimicrobials as safe, ineffective. I must just take them whenever I feel sick. So there are very similar drivers driving antimicrobial resistance compared to vaccination. And people have a lack of knowledge. This is just a study. You can go and look at it. They have a lack of knowledge, and many people have expectations of, of antimicrobials and getting antimicrobials. So we are busy with this study where we look at what people know, why are they using antibiotics, and how is it used, what are the language barriers, and how can we measure amongst the community, why they are using and what are they using antibiotics for. So we need to educate our patients. This is a massive window of opportunity. When you speak about vaccines, you must speak about antimicrobial resistance. When you speak about antibiotics or antimicrobial resistance, you need to speak about vaccines. There's no other way out. This is what we need to do now. So I just asked ChatGPT, how do you speak to patients about antimicrobial resistance and vaccination? And this is what he or she generated for me. So then I told him or her, now I don't like that vaccine, that syringe, because people have fear of needles. We shouldn't be putting needles in our poster. And then it gave me a new picture. But I mean, it took me 1 minute and it was done. So I mean, you can refine it, but just to show you, you don't need to battle. There are tools that can help you. Okay, so I'm running out of time. So the most trusted healthcare workers is you, the healthcare provider. All research has shown that. And we spoke about this the other day, but parents actually indicated what's the best reason for them to take for their child, to convince them for their child to take the HPV vaccine. And the best reason is it will prevent cancer. Okay. So when we speak to patients, so they want to know from you, the healthcare professional, from you, the scientist, what do you recommend? So it's always good to make, to emphasize the personal benefits, to make a strong recommendation, and then to address their common concerns. So I actually made this standard operating procedure, SOP, which is firstly, you need to make a strong recommendation, like it will prevent your child from getting cancer. Number 2, open dialogue, listen, never judge people, and number three, use the presumptive style. So it's very important how we communicate. You all need to know all these skills of good communication. Very important how you speak to people. So I've got some examples at the end of the slideshow that you can look at in terms of motivational interviewing as well as storytelling. I'm almost done here now. So when we debunk information, maybe Adele will also speak about it, but there is a debunking handbook. But just remember, you don't repeat the misinformation because it gets stuck in people's mind, okay? The other thing is I recommend that you don't use scare tactics, like put this picture out there and, be aware this is what's going to happen. So I'm not going to be able to go through these slides, but community engagement is very, very important. We spoke about it. You need to engage with the community. Find out from them, what do they want and what do they need? Make vaccines available, take them to the communities, reduce that cost, reduce the time. So there's some examples. I've got more examples at the end of the slideshow. And this is just the way forward. I mean, I spoke about all these things. Hesitancy is a problem. There's mis and disinformation, and it's in contrast with what our API programs are saying. The perceptions of risk is a very serious challenge. We need to be transparent in our communication, and we need to monitor vaccine safety. The regulator is responsible, but we need to help them. So thank you very much. It was very fast, and there are some additional slides.
Thank you. Thank you, Professor Anneli. That was a very informative presentation. So before we get questions from the hall, we have with us an important person, Professor Charles Wisonge, who has done quite a lot of incredible work in the field of public health. So we would like to steal some of your, yeah, we would like. So we want to steal a little bit of your wisdom. So what are your thoughts on vaccine hesitance?
Henry has said everything. That is it.
When I saw Charles arriving here, I was like, oh my goodness, now I have to perform. I'm so stressed now.
Okay, thank you very much and welcome. So are there any questions in the hall or perhaps online?
Thank you. It's not directed to you alone. I suppose anybody who is in NAC may also want to come in here. In the face of this disinformation, what is NAC or anybody else who is in the public sector trying to do to correct this, such that it's properly packaged and delivered for decision making?
Sorry, I didn't hear properly. So are you saying what is whoever doing at the moment?
Yes. In most cases, you are faced with disinformation, isn't it? You have information either not properly packed, but the issue is then with all this information on your table, what are the deliberate steps that are being taken to correct it?
Okay, so I think Adele is also going to speak about it, but what I didn't mention in my talk is that, as I've shown you, 65% of the misinformation and disinformation is spread by very few people. So my question is, where are all of us? So there are so many scientists out there with knowledge, and what we need to do is, if each one of us can just do one post per week on social media where these people are active, pointing out the benefits, like, for example, that very simple graphic that I've shown you that was generated by ChatGPT. If we can just do that, what is going to happen is all this disinformation and misinformation will be drowned. So there has been some studies who's already shown that. But I mean, I'm also one of the culprits. Are we doing it? Where are we? That's my question. So, you know, I actually have another slide from our Department of Health where they put something on the Facebook page about the benefits of HPV vaccination and so on. And when you look at the comments, it's only anti-vaxxers who are making comment. Nobody else makes a comment. So there are 20 comments or 40 comments, they're all anti-vaxxers. Where are the 10,000, 20, I don't know how many healthcare workers we have in the country? Where are we? So in my view, that's the only way that we are going to drown this mis and disinformation.
First of all, thank you, Prof. Hanley, for this wonderful presentation. I just, it's a recommendation. I just need to make an emphasize that one of the big barrier of risk assessment is social listening and infodemic management insights. Because information in the environment have a highly impact on public health decision. It is I see it is an economy of attention. So I think that websites, applications, Facebook are very addictive, and they have a lot of views, and these views is equal to money. Everyone here, for example, in Egypt, we have a lot of Facebook posts that tell from neighbors or from friends, they tell the insights, and that insight is affect others people or decision take vaccine or not. For example, I hear a lot about Zika virus, about Ebola, about yellow fever, and eventually about COVID-19 vaccine. For example, I hear that neighbor advise friends, don't take COVID-19 vaccine because my mom, when they take it, they get eventually into ICU. And they didn't mention it's already diabetes and is already elder age, and maybe there are another cause can admit her to ICU rather than vaccine. So I encourage that must be an authorized person from governments must be monitor these trends of Facebook, of this social media, and have a speed response that must be have speed response. So these anti-vaccines don't be make the huge insights.
Yeah. You know, you are absolutely right. So there are in our Department of Government, there are people doing social listening, but now you need to identify people who are, you know, seen as credible to then actually put the information out there and correct the information all the time, because of everything that has happened, there's a lot of lack of trust in the government. So they don't want to listen to what the government is saying in our country. So it all depends on your context. But yes, I absolutely agree. It needs to be a constant, you know, process taking place. So find out what's going on and come with masses of correct information. That's the only way. There's another question there.
Hanley, thank you for a great presentation. So just from a clinician's point of view, and especially at the time of COVID, so there are two things that clinicians faced. Okay, so that from my own perspective, I went back and was a clinician in COVID. We are not used to the aggressive behavior that is coming our way. So then clinicians were not able to defend themselves, okay, even with all the information and the knowledge. And then the other thing was that our councils, the Health Professions Council, and I'm on the British Council as well, does not allow you, it does not encourage you to, like, if you will, fight back, even with proper information. And so I'm just talking from my own personal point of view. That's what I found the most difficult. And then how people interpret information. It's hard enough for the scientists and the clinicians, never mind the public. So I don't know. So somewhere along that line, if we could help also the professions deal with this kind of situation. It's
Yes.
so huge. I don't know how to fix it.
You know, that's very, very important what you are saying. And we've been going around for quite some time now already, but nothing has changed yet, unfortunately, is that we need to bring this type of education in at primary school level, at secondary school level, at university level. Each and every healthcare professional getting a degree or training in this country should be, you know, getting this training on, for example, motivational interviewing, because it's a very specific way of interviewing people and bringing them to the point where they feel they themselves have made the decision. It's not you who made the decision for them, it's themselves. And that includes our dear journalists. Like if everybody could be like Adele, for example. So she makes sure she gets herself educated. So I set my alarm for you to go off just to draw your attention. But yes, that, I mean, it is a huge problem. It's a huge problem, but we are not trained in those skills. I mean, I wasn't trained in these skills. I've learned them now along the way. I'm not that I know exactly what to do, but it is really, it's very, very important. Yeah.
Thanks a lot, Professor Annelie. It's always very engaging, and there's still a lot of questions, but I'm sure you can meet up with her in person. And yeah, I'm very sorry.
And
Yeah.
unfortunately, we don't have all the answers now, but we'll keep on working and finding them.
Yeah, absolutely.
Thank you.
So next, thank you. So next on vaccine hesitancy and more specifically on how we can communicate, we have Adele Baleta, who is a freelance journalist, and she will be talking on vaccine communication strategies and media engagement for vaccinologists. And she's already there. Over to you.
Eager, keen, ready to go. Can I please ask Salim, can you bring that sheet over here, please? Thank you. Right, it's just fantastic to be here. I always welcome the opportunity to talk to people, no matter where they're from, because that's my job. Okay. But I'd like to start off by saying, I'd like to ask you something. Are we human? Okay. What does that mean? What does that actually mean? Do we feel things? Sometimes, interesting. Do we have emotions? We do, especially when people break up with us, right? Okay. Or if, you know, you get a flying glass your way or what have you. I think so. What is the best thing to do? Can you see this, you guys? Okay, well, it's okay because it's gonna be fun. We'll make it work, right? Okay, have we got a page? Okay, so we have emotions, right? We all eat, we all drink, we all know a lot of things. There are a lot of things that we have in common. What is the other thing that we need to do, okay, to be able to understand each other? Of course, communicate, okay? That's one of the greatest gifts we've got, right? And yet it is put to such misuse. And not only that, but it is not recognized. I mean, even in our relationships, we have to learn to communicate, and it's not an easy task. And the more we are practicing it, and the more we really think about it, and the more we put ourselves in positions of saying, okay, let me hear what you have to say. That's the hardest one, right? Giving a person a chance to speak. And that's what this is all about. I'm actually not going to be very complicated at all because I think it's actually very simple. So let's get out of our silos, get out of the labs, okay, get out of the offices, and let's meet here and let's talking about vaccines, okay? Sorry, I just have to say nice to see you, Charles. Okay, now, what I'm going to do is I'm going to take you through a few things. Okay, which is the way you go again? I never remember this sort of thing. Oh, there, okay. Okay, so some of the objectives that I have is just to look at the media landscape because that's where my home is, all right? The challenges that we face. How do we become social savvy? Because a lot of us sit here and we do social listening and we write papers and we do the research and we all know what's wrong. But you know, when you go back to your offices, it's really hard to remember or to think about, well, now what? How do I go about this? And I think that is the central point. We've got to actually translate what we know to be the problem, because we sit and we can talk about high vaccination, low vaccination uptake. We know all the miserable things. And I'm actually thinking we need to move to a place of more positivity. In other words, action. So I'm going to tell you a little about what journalists do, about which you can do, a little bit about what COVID teaches, what taught us, because we need to learn from lessons, obviously. So these are the challenges. We've had an infodemic, okay? And we do know that that has also meant misinformation and disinformation. And there is a very real difference because journalists get blamed a lot for spreading misinformation. But if you really think about that definition, which has been talked about before, it's important because misinformation is not doing something deliberately. We're not going out there to cause harm. Okay, many science journalists and health journalists actually are out there because they want to do good for the community. And that's actually a fact. They don't go out with malicious intent, but they get it wrong. And a lot of the time they get it wrong because they are not being shown or they're not given credible information or information that they can use. Lots of distrust of evidence-based science, as we've seen. Trust, oh my word, we know. Okay, people want your transparency. They want your honesty. They don't, they because of social media, they are now over it. They don't want to be tricked. They don't want to be fooled. Very important that. But also scientific uncertainty. They don't understand it because they don't understand the scientific method, and why should they? Many people in our countries there's no science literacy. So all they want to know is, doc, is it this or is it that? They don't know and they don't understand why you can't answer a straight question. There's more attention to more risks than benefits. And of course, there's also vaccine hesitancy. So let's just have a look quickly at the landscape. So internet user growth worldwide from 2017 to 2028 in billions. And you can see it's gone up to 6 billion, which is sizable and it's growing. Okay. This one here is the number of internet users in Africa as of February in millions, and Nigeria tops the list. Okay, followed by Egypt, South Africa sitting there at 50.8 million, 10 million shy of our total population. Then we've got Algeria, Morocco, and so on. Cote d'Ivoire comes in at 12.8, Cameroon at 12.4. But it's growing, and we know this, okay? Most popular social networks, what are they? Facebook, YouTube, WhatsApp, Instagram, Facebook Messenger, TikTok, and so on, okay? Very, very significant. So internet usage, okay, as of January 21, Southern Africa, okay, was the region with the highest internet penetration rate in Africa at 66%. And then by 2024, it's climbed to 75.9%. Eastern and Central Africa, not as prolific. In South Africans in 2021, 36 million, okay, accessed the internet through any kind of mobile devices, okay. In January 2025, this grew to 50.8 million. So there, it's happening, right? Now, there's something that I also wanted to address, is that you would say to me that in your world, things change. Isn't that so? And to meet those changes, we have to introduce vaccines. We've got to develop new vaccines. Isn't that so? So why can't you say the same about communication? It's the same. We live in parallel universes, actually, because in fact, the way that we communicate today is different from yesterday. So what I'm really saying to you is catch a wake-up call. Don't be stuck in the past. So where if something happens, if there's an event or something and vaccine deniers are all about their business because they're very, very vocal. And what happens is that you can go onto 60 Minutes and you can actually debunk that just like that. It doesn't work anymore because people aren't there. Okay, they're on YouTube, they're on WhatsApp, they're on Insta, and so on. So catch a wake-up call, guys. Okay, there's no time now. You've got to change the way that you work in terms of communication. Social media. Okay, so their Instagram, they offer different opportunities to send a message. So Instagram, visually appealing posts, stories and reels. Then you can use hashtags. Facebook, you can create detailed posts, okay, host live Q&A sessions with healthcare experts and share educational articles. Twitter, I don't use Twitter anymore, so I don't really want to advertise Twitter, but still you may be needing to be there. I'm on Threads, okay? Post quick facts, share news articles. It operates in exactly the same way, different bosses. Okay, TikTok, very important there, very important for the adolescents. Okay, and we're going to come back to that. It's an engaging and informative short videos targeting a younger audience. Very important place for you to be, actually. Agree? Good. Okay, so now I want to show you something. I want you to listen to this. This is a doctor, Dr. Michael, or Dr. Mike, as he's known on TikTok and on YouTube. Now, Dr. Mike, okay, was invited to what's called the Jubilee debates in America. There, your worst nightmare, all of you, okay, is that he had to face 20 vaccine denialists, all young, well, mainly young, okay? And the way that it works is that he sits, okay, there's a clock, and then somebody comes, there's a race to the clock so that the first person that lands in the chair is the person that actually gets to ask him questions, right? So now this is him responding to one of those people. Have a look. Go and have a look, okay? Here it goes. Let's see how that works. I hope it does work. Oh, volume?
I just had a baby, 7 months old. And my baby, I was like, no, I'm not going to get the vaccine. The doctors came in, they made me feel like a very bad mother.
Non-judgmental. You'll never forget that now. Okay, non-judgmental. Anybody else? Empathy. Evidence-based. Transparent. Sorry, I need my glasses. What was that? Practical. Simple language. Honest. Storytelling. Accountable. Yes, I like that. Okay, what else? Relatable. Relatable. Success? Okay, so I don't know whether that actually changed her mind or not. Okay, and it's unlikely to have. But why I'm showing you this, okay, is because this is the kind of communication you use with the vaccine hesitant. Okay? That is going to where the human being is. All right? So he may have changed her mind because sometimes people do get their minds changed. It's unlikely with the vaccine denialists, but I was amazed. And I was thinking that if anybody that was on the edge, on the fence, listened to that, you see, that's what I'm looking for. That's what I'm looking for, because I promise you something, the algorithm and the way that it works on TikTok is that it's reaching many, many people. Okay, so let's see what he said. He was actually interviewed in Stat News. You know Stat, the platform, the journal. It's not a journal, it's actually, it's an online journal, okay? This is what he said about what that experience was like. His name is Dr. Mike Varashki. This is what he learned. He said that he felt, now he had also, don't forget, he'd spoken to 20 people and they went through everything that you can imagine about how bad vaccines are. He came up with the conclusion that he feels that there was a terrible interaction with healthcare providers. Okay, we have missed a major opportunity, he said, because the gap, we're on the back foot. We're actually on the back foot now. The gap has been filled by grifters and by snake oil salesmen. They got right in there, which is what's been happening all along since in the Great West, okay, the Wild West, when there were cowboys and, you know, Indians, and they were all fighting each other and what have you, and in came the actual snake oil salesman. I got a miracle cure, etc., etc. So they're always very, very good at promoting. They just are. So we've got to become better at that. Okay, so it's a missed opportunity. We need to invest in and learn about social media tools. We've got to do it if we're going to try and keep up with the front runners. Okay, and then he realized, okay, loss of trust in health systems. And then he also said, you know, we crave certainty. And he gave us an incredible example about during the COVID-19 era when we so desperately want to put messages out there in a panic-driven way that we needed to feel that we had to offer everybody some certainty. So when it came to COVID boosters, we just give them to everybody, okay? And people felt tricked about that. So because we were on the back foot, we're not ahead of the curve, okay? He's got 14.4 million subscribers on YouTube. And why? Because his content is relatable, because he loses the jargon, and because he gives accurate information, which is what you got. Okay? He says, we've got to study the algorithms. We've got to understand how the different platforms work. And what he said he did, okay, is that he did a lot of trying to understand. He made some mistakes. He went back. It's practice, you see. Practice. That's how you learn to become a concert pianist, okay? So what's important here is that he said he also got people that were online on these various platforms to come in and to show him how. So why don't you do that? Okay, invest in that. Get, say, somebody who's really, really popular, maybe an influencer, just depends, you've got to be careful about that. What are they an influencer for? How do they do it? Because you don't know, we don't know, I don't even know, okay? Make science enjoyable. Be entertaining, okay? And this is what he says. He says content needs to be seen through a human lens first. All right, now, he's also very clear, and we had this little discussion here amongst us, the little chat, okay? We were talking about what it is, is that you're sitting in the lab, you're a researcher, and what you become aware of is actually there's so much going on out there, right, that you have no idea about, and that you expect once your research paper is out there, okay, that it's going to be read and that it's going to be communicated, and not so. It doesn't work like that. So let's just remember that people who are hesitant. Oh, sorry, wait a minute. I think I dropped some. Yeah. Okay, so facts alone don't change minds, especially when people feel unheard and unseen. Okay, very important. And it actually doesn't mean, once you get that, once you really, really get that, I think that messaging is a lot easier, to be honest. Okay, so let's move on. Uncertainty, I think, is very important, and it's come up a few times in these talks. What's important here, okay, is that, again, people don't understand uncertainty. As I said before, there is this thing that, everybody needs to be certain. Just being a parent, you need to be certain of the whereabouts of your child. Isn't that so? You need to be certain about the welfare of your child. So when people don't understand science, okay, they don't understand that science evolves. Now, you can explain that, can't you? One could stand and sit at an interview situation and say that science is the most precious thing that we have, okay, because it takes us to new places. You can use different analogies. You can talk about, we've gone to space, okay? We've managed to get vaccines that have prevented major infections, all right? But it's a journey, okay? And that journey takes time. So it's not a yes or no answer. It can only tell you what we can with the evidence that we have. And then you put emphasis on evidence, because if we don't have the evidence, then what's the point? So when it comes to things like complementary medicine and traditional medicine, okay, fine. As a journalist, I'm going to say, I'm delighted. What evidence do you have? Oh, well, Mary down the road, okay, she took that and it worked beautifully for her. It's not going to wash with me, because as a science journalist, show me the evidence. Has it been through a clinical trial? And that's what we teach journalists, okay, what to ask. That's what we tell them. So for Fauci, I really like this. He came under so much pressure in the United States. And he said here, the people who are giving the ad hominems, in other words, those people that are attacking him, say, Mr. Fauci misled us. First he said no masks, then he said masks. Well, let me give you a flash. That's the way science works. You work with the data you have at the time. It is essential as a scientist that you evolve your opinion and your recommendations based on the data as it evolves. That is the nature of science. It is a self-correcting process. And that's the reason why I say people who then criticize me about that are actually criticizing science. It was not a change because I felt like flip-flopping. It was a change because the evidence changed, the data changed. Now, you can say something like that in a much more simple way. You can talk about a journey. You can use different metaphors. Okay, so whenever you get an opportunity, you can say, I understand people are confused. I realize there's uncertainty. I understand that uncertainty makes you feel uncomfortable. But there is something about the scientific method. We have to do our experiments, or we have to do our clinical trials before we can feel so confident to stand in front of you and say it's 100% effective. That is why we would never put out a vaccine that isn't effective or that isn't safe. And then you can go into another story. It's storytelling, guys. That's what this is about. So your target audience, well, we've already said here, what are the chances of changing their minds? Okay, vaccine deniers, very low. So we're wanting to know, with our time and with our money, where should we be going, right? So vaccine denialists, I can't see. Okay, thank you. Okay, so vaccine refusers, it's low, but where do we need to be with the actual the hesitant individual? Okay, we've already decided on that. Okay, then factors leading to hesitancy, we've already seen a bit of this. The WHO talks about the 3 C's. Okay, and that's complacency. Well, it's a low perceived risk of vaccine preventable diseases. I don't think I really need it, so I've got other priorities, right? Barriers related to geographic accessibility, availability, affordability, and acceptability of services, right? We know that too. Now, confidence, low levels of trust in the vaccine system or in the vaccines. Okay, so that is what we understand with all of our studies, behavioral studies, whatever, that is behind some of the hesitancy. So it's not black or white, there are different shades. Okay, and that's important for us to understand that. How will we understand that? We'll understand that by not just hearing people, but by listening to them. Okay, we need to listen actively. Not how you listen to your children, because I can tell you something, that's most of the problems that we have is because they're going to tell us, you never listen to me, you never listen to me, okay? And we often don't, actually, so they're right. We need to actively listen, and we need to show empathy. We need to validate people. In other words, show them emotional concerns, for their emotional concerns. We need to say, I understand, or that must be difficult. And then we give the facts. And then inform, we must give trusted sources and relatable stories. Every person you listen to is a brick in the bridge of trust. So you want to say, oh, trust, it's such a big word. How are we ever going to get there? We'll never get there. The point is that you've got to start somewhere. And I argue that this is where you start. So get back to being a human, okay, and not a bionic machine. Breathe deeply. Do some meditation or yoga or whatever is required, because that will bring you back into your body and it will actually make you realize this here is an opportunity for me to get my message across. Rebuilding trust takes time, but every conversation counts. Okay, now a little bit for support for health workers. Okay, I'm not going to go into this in depth, but you know, let's kind of be, instead of that whole thing about, oh, the nurses, they are right at the epicenter of this because they are the ones that are on the ground. So why don't we give them credit? Why don't we understand that they are at the coalface? They're probably burned out. We're not updating them on the latest evidence. We should go down there and support them in conversations with people that are hesitant. Why are we not doing that? They need bite-sized, digestible information on new vaccines. Oh, it eventually comes probably down the line, but why isn't it there before the vaccine arrives so they can digest it? Why not? To me, that doesn't make any sense. They need empathy and preparation and appreciation. And I really do believe that's important. So, you know, instead of hitting them, you know, oh, we've got to really talk to people, show them how. Show them how to do it. We know what needs to be done. It's the how now. Don't forget the adolescents. And I believe that the adolescents are one of the strongest groups of people that you should be engaging with, okay? And why do I say this? Well, the first experience of information that adolescents have been exposed to at this time, okay, YouTube, TikTok, Instagram, first information, okay, apart from textbooks at school. And this is where they sit most of their time anyway. This is how to reach young people. And remember, they are not passive recipients of information. Oh, what happened there? Okay, I don't know how that happened. Salim, I need your help, please. I've done something funny here. what I've done is that, oh, that's you. Okay, thank you. Okay. They are not, okay, so they are connectors, right? They are connectors and translators. They're also leaders, okay? Because why? Because they educate their peers. So I've also had this idea that instead of this debunking, we talk about debunking and it's such a nice word. Why don't we talk about pre-bunking? Why don't we talk about pre-bunking in the adolescent group? Because we can actually say, you know, you may come across people online who are saying this, and this with malicious intent. But they are not people that we should be trusting. So you want to get people early because they're formulating ideas already, okay? They're formulating opinions already. Get them early. Adolescents are really important. I mean, I don't really like them very much, you know, based on my experience, but they are really the ones that, they're the ones that are the engine, I believe, okay, of the future. Okay, so how to communicate with journalists, just very quickly, build a professional relationship with them. Contact trusted journalists if a rumor starts to circulate before a crisis develops. You can give them the facts. Messages must be simple and answer questions and be completely honest. Refer to someone who knows the answer if you don't. Now, that guy, Dr. Mike, was extraordinarily honest and transparent. And you all appreciated it because you picked it up. You should be doing the same. Okay, give your contact information so the journalist can follow up the story or check facts with you. Remain polite and professional at all times. Don't lose your temper, even if you are provoked. So, you know, going back to the thing about how do you deal with aggressive people? You know, I'm a clinician. I don't know how to do that. I feel like I'm on the back foot. This comes into being human. And it's about reading signs. It's about reading that person. Okay, what is going on here? This person is coming on very aggressive. So I'm just going to let them rave for a while, keep quiet, breathe deeply, okay, and then respond with the messages that I have prepared before, that I know so well that I'm not going to be rattled. Because remember, that's how people want to see. It's very important, this, because if you have that kind of demeanor, what do you think it does? It's like another brick in the wall. It's like another brick in the trust wall. Okay. Remember that journalists are not interested in destroying your reputation or tricking you. But if you allow them to, they will. And I've done it. Okay. I've destroyed people's reputations, as have my friends. Okay, so never lie, never say no comment. That's a bad one. What can you say instead? Yes. 100%. You redirect the conversation towards what you want to say, okay? You use a bridge so you can say, I hear what you're saying, but did I tell you that? Blah, 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 blah. You see, if you say no comment, what does that come across as? Anybody? What? Lack of knowledge of what you're talking about. Hiding something. Disinterested, maybe? Yes. Don't care? Yes. So how is that a brick in the wall of trust? Exactly. So a no comment is a very bad thing to say in the media or anywhere, because to me, it reads unaccountability. Remember, your job is also paid for, usually, okay, by the taxpayer. You are accountable to us. So, talk. Okay, so there's never an off the record, all right? There's never an off the record. Be careful of that. We can talk about that later. Stay calm and confident. okay? Simple language, avoid jargon, stay in control. It's okay to say, I don't know, but I'll find out. That's very different. I can't answer that question and I will find out, however, and you move to something that you want to speak about. Okay. We like accuracy and simplicity. So I'm just going to tell you what I want from you, as simple as that. I want statistics with explanation. If you start going into all your little graphs and all your stuff, I'm sorry, you've lost me. I'm gone. So what you want to do is you want to talk about pictures. So this is, and I'm so delighted because there are 2 people in this room that have used my suggestion in their slides. I am so delighted, okay? I think it was Claire that used the example of, I don't know, I can't even remember because I just picked up when I heard. She showed an airplane and she was talking about how many people died in, if a plane crashed, it was equal to, let's just say 500 maternal deaths a day. Pew, picture, get it. Right? Make pictures for your audience. 1 in 1,000, 1 child in a high school of 1,000 pupils. Got it? Got it? Good. Okay, some context or background. I want the highest authority possible. If you don't give me that, it's okay. I'll go to the tea lady, boy. That's what I'll do, and I'll get my story. Human interest angles and fast responses. Okay, we hate evasiveness. We know when you're hiding. We know when you are passing us from one person to another. Okay, and we don't like being patronized. We don't like being spoken down to. You've got to do something about your jargon, okay? And we don't like dishonesty. Now, guys, just think about this, okay? You're going for an interview and you haven't prepared, right? Here, top pocket, ladies, a pocket here, maybe, or what have you. Print yourself a little card. I've got a little card like that, and I need to bring it and you think I could find it. Okay, so what you do is you take it out and you do oh, sorry, yeah. I like to do who, what, why, when, where. That is what you're going to be asked. So let's get over it. When did this happen? Location. Let's say it's a side effect. Oh, let's say it's an adverse event, right? Where did it happen? Okay, what village, what region? Who is responsible? Who did it happen to? What went wrong? Yes? And why? Why were you not on this? Why did you not anticipate this? Okay? And how could you let this happen? So there it is. Prepare. There you go. That's what it's about. Okay? This is very, very simple, actually, at the end of the day. Sorry? 2 minutes. My goodness me. Okay, let's move very, very fast. Now, what have I done with that thing? Yeah. Okay. So now these are other important points to participate or not, okay, in a situation where you've been invited to respond to an anti-vaccine stance, okay? Well, it could be an opportunity to deliver key messages, to appeal to an audience, to inform undecided individuals, but you've got to be very careful. So I have a friend, okay, who is often asked to be interviewed, and he has got a very, very, very clear line. And he happened to be visiting, and he said, oh my word, I've got to actually phone in now, I've got a radio interview. So he then, but actually before that happened, he didn't have the interview then, they were booking him for the interview. So he said, okay, what's it going to be about? So he said, well, it's about vaccination and et cetera, et cetera. So then what happened after that, he said, am I sharing the time with some other panelist or person on the radio? And they said, yes. So he said, well, can you tell me about them? So they said, yes, they're taking an anti-vaccination stance. So he said, that's interesting. So he said, how much of the time is going to be given to them and how much of the time is going to be given to me? And they said 50-50. And he said, I'm sorry, I can't do that. Your default microphone. Okay. Okay, so he decided no. And the reason that he decided no was because he felt that unless he was given 80% of the time, then there's an equal chance that people will listen to the anti-vaxxer. And he did the right thing. So now they don't have a person pro-vaccine, so people will understand possibly that that's just an anti-vaccination stance. So that's, I thought, was very clever. Okay. There's something going on here, Salim. I don't know why it's talking to me. Okay, so things to think about. Are you the best person to do the interview? Are time and resources available for preparation of messages? Is it a serious format? Okay. And is the audience large or strategic enough to justify participation? Will the discussion be sufficiently balanced and unbiased? You do not have to go to an interview. I'm sorry, it's echoing. So you don't have to go to an interview. You've got to be strategic about it. You've got to decide whether you want to go or not. Okay, let's move on. Now I need to take another 2 minutes. See, bargain. So 50%, 50%, no, 80%, 90%, 10%. Okay, I'll go 80%, 20%. Be confident, take a bit of control. I'm muted still. Yeah. Okay, so now I'm going to move on and I'm going to ask you something. Talk about opportunities to Can you hear me? Yeah. Okay. Oh, the online people. I'm sorry, online people. Okay, so what I want you to think about is, where do you think you can have an opportunity to spread the message of vaccination? Yep. Excellent. Anybody else? Anybody else? Yeah, just shout. I don't have time. Yes. Church, maybe, definitely. Right. School, definitely. Why are we not sending people to school? 2 people. That's all you need to go and speak to adolescents about vaccination. Why are we not doing that? Parents. Okay, but where are we going to get them? At the school. I do need a little bit more time. Yes? Okay, community radios, absolutely. Yeah, okay. I'm thinking of other places now. Market. I do like that. I do like that a lot. I didn't think of that actually. Where else? Shabeen. What does that say about you, Greg? He says with a big smile on his face. Community gatherings. Perfect. Gatherings. Okay, anybody else? Oh, I didn't think of that one either. Well, that's excellent. Funeral.
Do you mind asking the question again using the mic? The online people are saying they missed the question.
Okay, the question was very much, where can you think of places where you can talk about vaccines? In other words, spread the message. Have a conversation about vaccines. And look what we've got. Yes.
I'm just thinking now, the Springboks and their trip all the way overseas, if they were more open, they're definitely vaccinated to the hilt. Right. And why isn't that being mentioned? Why isn't like, oh, all the Bokke got their vaccines today? Somebody's pointing.
Anele, did you hear that? Please stand up. Where is the vaccinate on the shirt? But that's a very good point. So I'm going to put sports circles. Okay. Hospitals.
Professional groups and hospitals, because, you know, in COVID, you need to have the ONGs in, you need to have the trauma people in who are seeing the respiratory failures coming through the door, the cardiothoracics who are, and actually that's how South Africa had a huge group of cardiothoracics and trauma-based surgeons and physicians who did a lot of healthcare professional education.
So I think that is a very valid point. And why I'm saying that is because also the opposite happened. Those people that weren't part of that fold, okay, were out there giving incorrect information from the basis of being so-called medical experts. Those cardiologists, one in particular I have in mind, who's still sowing seeds of misinformation, knows nothing about vaccinology or immunology. So that is a very, very important point, okay? So what I'm going to do, because I'm now being harassed. Okay, so those are mine. When antimicrobial resistance comes up, vaccination campaigns. You write in it, you might as well talk. Okay, the introduction of new vaccines, talk about other vaccines. Declining coverage rates are reported, when increasing coverage rates are reported, when there's a change in the program, a vaccine switch, dose, or schedule changes, adverse reactions, when there's rumors and misinformation. National immunization weeks, okay, infectious disease days on the health calendar, meetings, seminars, symposia, conferences, blah, 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 community workshops and meetings, school meetings, church. And then what about the minister? You might be going there for some other reason, but then you can also still talk to him about vaccines, okay? And why is that important? It's important. Oh, I'll tell you why I put that in, because I wanted to be reminded of one fact. And that is that we talked about speaking to the minister, and we talked about, okay, you know, you've got to go in there, begging bowl in hand, doing the, you know, sort of salutations and so on. Remember, they have very big egos. So the one trick is to turn around and to say to their minister, do you know what this is going to do for your career? Minister, do you know how people are going to love you for this? Minister, do you realize what a caring person you're going to come out looking like? So appeal to the human. Okay. So also in the Uber, right? On the bus and in the shower. So what does that mean? Okay, I found myself going into the shower last night, and instead of asking my husband if he had had his shower, I said, have you had your vaccine? Oh, it's too much. Okay. So spread your key messages, which I'm not going to go into now, but you need to learn about your key messages and what is the most important message that you want to give people. And then finally, I want to just show you the slide about numbers, about how you talk about numbers, because people don't all understand numbers, okay? Tell stories around the numbers. And this is just a little light relief because it is the end of your day, and why not? So this guy that you can see in the picture, which I'm going to show now, is a person who is explaining to his parents how the inheritance of the farm should be divided up, okay, in terms of money.
I figure 75% to you, Pon Ma, and 25% to percentage. I figure 75% to you, Pon Ma, and 25% divided between the five of us.
Yeah,
Gida, Crowbar, myself, Tom, and the baby. That makes 5% for each
it's
one
really
of us.
impossible to
Billy,
cover
you're cheating
so
yourself.
much. So I appeal to you,
If
any
there's
media training that you can
25%
get,
divided
get.
among the five of
Because
you,
in fact, that
that's
guy that I showed you,
14%
Dr.
apiece.
Mike, when I listened to him, and you can see it on Stat News if you look him up, okay, and see the video, he's just talking about what we do as journalists. getting like really good headlines, thinking about stories, thinking about how to use, you know, the various tools. And that's where we are at now. And you really, in my view, can't afford to not be there, because that's where your constituency is. That's where the people that you need to reach are, quickly and efficiently. Sorry.
Sent to you, Panma. And 20 percentage. I figure 75% to you, Panma. And 25% divided between the 5 of us. Yida, Crowbar, myself, Tom, and the baby. That makes 5% for each one of us.
Billy, you're cheating yourself. If there's 25% divided among the 5 of you, that's 14% apiece.
Oh, no, listen, Pa. I wouldn't cheat you. You know I wouldn't. Now, look here. I'll show you. Let me rub this out here. And now, 25 divided by 5 is 5. You see, 5 won't go into 2, will it? No. But 5 goes into 25 5 times, you see?
No, you're wrong, Billy. Now, I'm a pretty good mathematician. Now, 5 into 25, 5 won't go into 2, will it?
No.
But 5 goes into 5 once. Now, we didn't use the 2 before, so we bring it down here. Now, 5 into 20 goes 4 times. There you are. 5 into 25, 14.
No, look, Pa. Let me prove it to you now by multiplication. 5 times 5. 5 times 5 is 25.
Really, I'm surprised you're learning.
Huh?
I'm surprised that you're learning. Now I'll show you. 5 times 14 is 25. 5 times 4 is 20. 5 times 1 is 5. 25. That's it.
No, look, Ma. See, look, you're wrong there because I'll prove it to you. We'll put down 5 14s here. 14, 14, 14. There. Now I'll prove to you by addition that 5 14s is not 25. 4, 8, 12, 16, 20.
21, 22, 23, 24, 25. There you are. Now to brush up, Billy. I don't want to see you boys cheated.
Okay, any questions?
Yes, so yes, I will get to you. Please, a big round of applause to Adele for keeping our very last session so engaging. Unfortunately, we went so much above the time. So Adele is still around. Please make sure to reach out to her with any question that you have. So we have one question online. And
we have a question from Abdul. He's saying, how do we rebuild vaccine confidence in communities where past medical actions created deep generational distrust? So he's saying, take northern Nigeria, for example, in the city of Kano, for example, in 1996. Unsanctioned Pfizer meningitis drug trial left many people dead with disabilities and unresolved trauma because the medics framed it as a Pfizer vaccine. The stigma attached itself to immunization programs for years to come. So his question is, when that kind of history shapes collective memory, what strategies actually work to restore credibility and get communities to trust new vaccines that are getting introduced?
Okay, so I don't know about that incident, but I know about the incident with, I think it was the polio vaccine in about 2004 in Kano. Okay, so yeah, it's difficult. It's extraordinarily tough, but we've got to start somewhere. The first thing is to go there. We need to go there. We need to show that we care, and we need to take top people to Kano to talk to the community, to the religious leaders, to the imam, whoever, the pastors, and open a dialogue. Because you cannot do it from an office in Lagos. It's unacceptable. You need to go there and you need to start building brick by brick and explain what actually happened. Everybody makes mistakes, okay? People understand that. Why? Because they're human, right? So everything is about being there, being seen to be there, having tea, sitting down with the imam and taking time because people want to be seen and they want to be heard and they want you to understand that they count. And that is the first steps of actually rebuilding trust and then creating a good network of communication so that that sort of thing hopefully doesn't happen again.
Thank you. So it's like just adding to what you're saying, and based, I think everyone are aware that I'm conducting study in Cape Town among over 1,000, a cohort of 1,000 pregnant women, and it's about decision making during pregnancy, or but it's towards all vaccines. So when we ask them about their source of information on vaccines, first of all, they all don't, like, they are aware they cannot trust social media, information on social media, but the main source, it's TV and the news. And during interviews, I found, because some of them think that they cannot put something wrong on the TV. So we still need to target, programs on TV and news. That's always the number one source of information on vaccination in general.
Absolutely. So just to reply to that, okay, I wish I could have shown you another video, but time doesn't permit, about how people do get it wrong, okay, on television. So you need to become media savvy. You need to learn how to be interviewed. You've got to actually go for training, or you've got to practice amongst yourselves. Hard questions, 1, 2, 3, have the answers and prepare your responses. Okay, yeah.
Please, another big round of applause for Adele. For keeping our very, very last session so engaging and interesting. So thank you, Adele. Thank you. Yeah, so but before we go to our daily evaluations, I love surprises even when they are not for me. So I believe Greg has something for somebody. I don't know. Okay.
So Adele, thanks very much. I mean, you've been doing this for the last 20 years. So maybe we should run a special course on communication for healthcare workers. So maybe next year we'll have a 2-week course. So you can all come back again next year for Adele special. We call it the Adele special. All right. So all of you know that Sunday part